Yes,
Chitra?
ma'am. Yes, ma'am.
Yeah.
We are live now. ma'am.
Yeah. Just start, Chitra. We're online.
Yes, you can start, Chitra.
Chitra, you can start, ma'am.
Kavita, your face is half hidden.
Akila, ma'am.
Akila, I'll start, Akila. So it gives me a great pleasure and honor to welcome to this webinar of all Odisha Bihar societies with Obstetric Gynec Society of South India. We have the Contraceptive Committee of OXY with all the societies, and we welcome you for the Women's Midlife, Reproductive and Sexual Health series. And I have the great pleasure and honor to welcome all the senior faculties and all the mentors, teachers, and all the Foxians here for this webinar. I request Akila to start the webinar, ma'am.
I extend my warm welcome to all the delegates across the country. But for President Madam, it's difficult to gather, put such a big gathering with all senior peoples. We welcome you to guide us through the contraception session today, this evening. First, we begin with the lighting of Kutuvalakar. Yes, ma'am. I welcome our President, Dr. Jairani Madam, who's a senior consultant in... Yes. Ma'am, am I audible?
Yes.
You're audible. Keep going, ma'am.
Yes, I welcome our President, Dr. Jairani Kamrar, who's a senior consultant in reproductive medicine. She's a director of Akash Fertility Center and Hospital in Chennai. Madam is the current president of the. She's a treasurer in.
Yeah. It's okay, Akila.
Yes, madam. So I think you don't need any introduction, ma'am. Over to you, madam, to deliver the welcome address.
Thank you, Akila. Thank you. Good evening, everyone, and good evening, all the presidents, secretaries, and my mentor, Dr. PC sir, Dr. Rajat sir, Madam Alka madam, and all the senior faculties, and my dear friend Meena, my dear friend Supriya, and Suman. It gives me a great pleasure and honor to welcome you one and all for this webinar, which is a collaborative one along with OXY, our contraception committee, along with Bihar societies and Orissa societies, to have a joint webinar on the women's reproductive health care. So it gives me a great pleasure to welcome all the senior faculties here. The chief guest for this webinar, Dr. PC Mahapatra sir. Sir, don't need any introduction. He's such a great man, but with a simple heart, with a loving heart, with so much emotionally touched with all the women healthcare all over country, and all with the obstetricians all over the country, sir. Sir, it gives me great pleasure to introduce and welcome you for this webinar. And thank you for accepting our invite to be the chief guest for this webinar, sir. And sir, for your kind words for this webinar, sir. Sir, please unmute, sir.
Please unmute, sir.
Thank you, Jairani, for inviting me, an expatriate person, and overestimating me in introducing the audience. And in fact, Jairani and Suman both have emotionally blackmailed me so that I'm here. Well, at the outset, I must congratulate all the organizers, and you've been able to have a good academic conglomeration of all Orissa, Bihar societies, along with the Obstetrician Society of South Orissa, South India. And special compliments to you, Jairani, Suman Sinha, and the vibrant secretary of this OGSSI, Kundan. And Kundavi is a very dynamic secretary, I know. And I welcome all the guests of honor, the vibrant MC Patel, the Alka Pandey, the dynamic vice president of Foxy, and Dr. Rajat Mahanti, the ex-vice president of Foxy. And I congratulate, I've seen the scientific agenda and the module you have created for this unique midlife reproductive and sexual health, and which again I welcome Meena Samant, Deepa, Dina Baru, and Dr. Dhanalakshmi, and the whole of the panelists in this particularly total session has been designed so aptly for the reproductive and sexual health of midlife, and starting with the bone and sexual health, muscle health, and the different aspects of contraception will be discussed in the panel. And I think this will be a challenge to the midlife management plan, and it's a right forum to discuss about the various aspects in relation to the reproductive and sexual health of midlife women for them. I wish this particular webinar will be really a great opportunity to have an update on knowledge of the viewers across the country, and thanks all the societies of Orissa, Bihar, and the OGSSI for this effort, and compliments to Jairani and Suman for the effort you have undertaken for them. And it will be really a unique opportunity to me to be with you, not as a chief guest, but to learn many things from you. Thank you very much, all of you, for that.
Thank you, sir. Thank you. Thank you, sir. Thank you for your kind words. And we really look
Thank
forward
you.
to have this, sir. Thank you so much for blessing us. And over to Suman.
Thank you.
Suman.
Thank you, Jairani, for giving me this wonderful opportunity. Really, I'm really so much thankful to have the galaxy of stalwarts from Foxy, from the entire nation. We have Dr. P.C. Mahapatra, sir, as our chief guest, Dr. Rajat Mohanty, sir, as our guest of honor, Alka Di, our own Alka Di, as our next guest of honor, and we are missing MC Patel, sir, because he's just boarded the flight. But I welcome all the faculties, Dr. Meena Samant, Dr. Supriya Jaswal, Dr. Dhan Lakshmi, Dr. Kavita, Dr. Deepa, I can see Dr. Ranjana Jha, Dr. Neelam Sinha, madam, everybody is there. So a very warm welcome to all of you, because this is Sunday evening and I was knowing everybody must have been busy and taking some of the time for us. It's really full of, we are full of gratitude to you all. And I'm expecting a very, a very good scientific session, because you will make it. And I know we have collected all the wonders from Odisha, from Bihar, and from Tamil Nadu. So without wasting time, I would like to introduce Dr. Rajat Mohanty, sir. Can I have his slide? So as we all know, Dr. Rajat Mohanty, sir, and myself is associated since last 20 years. And he's been with me. When we start talking, we don't leave the phone. We talk for more than 30 minutes. So this is special compliment to me from sir. And we all know him. He has been the ex-vice president of Foxy, and very kind and noble person, a big educationist, you can say, friend, philosopher, and guide and mentor to most of us. So he rather needs no introduction. His big career in Foxy IC as vice president, chairperson, midlife management committee, governing council member, and whatnot. And we expect you to rise more and more, sir, in your future endeavors. So we welcome you, and we are eager to hear your precious words. So over to you, Rajat Mohanty, sir.
Thank you, Dr. Suman and Dr. Janani, to calling me here as guest of honor. So after good evening, everybody, and welcome to this live webinar on women's midlife, reproductive, and sexual health. this midlife management committee, actually, I was a chairperson. It is very touched to my heart. I had working for since 1909 to 14 in this committee. So it is a very favorite committee for me. Most important expected midlife transitions are 5 points. That is accommodation, separation, liminal reintegration, and individualization. So it is a matter of right and dignity for me to participate in this intellectual gathering consisting of Southern India, Odisha, and Bihar Obstetrics and Gynecological Society. This webinar not only encourages our friends to uphold the knowledge about midlife reproductive and sexual health crisis and also their management. In this scientific congregation, I want to mention few words. This is a very important few words regarding upcoming Foxy election, which will start from next week. I have perhaps since last few months about my friends, our friends, who has really worked hard day and night and became panic about Foxy election. So my appeal to our friends, we are all friends, doctors, scientists, not politicians. So please select the perfect and worth candidates for betterment of future Foxy work. So I wish all the success of this webinar, and I am very much thankful for calling me. And I saw that there are many speakers and panelists are there. Dr. Suman, she was my chairperson in clinical research. She did a lot of good work in her tenure. So I wish long live Foxy. Thank you very much.
Thank you, sir. Thank you. Thank you so much, sir. Thank you for your kind words, and thank you for all the inspiration, and thank you for all your vision. And we really look forward to work with your vision in this in our tenure in Foxy, sir. Thank you so much, sir, for being with us.
Wish you all the best. All the best.
Thank you, sir.
I
Thank
wish
you,
all
sir.
the success of this webinar, particularly. This is a very good scientific. I'm happy very much about listening about this webinar. Thank you very much. Thank you.
Thank you so much, sir. Thank you for your kind words, sir. I have the great pleasure, honor to introduce Dr. Alka Madam, who is a very much kind person, who is a present Foxy Vice President. Madam is so much for her very kindness, and also for the dynamicity which she shows in her tenure as the Vice President. And she's now the member governing council of ICOG. She's the chairperson of the Practical Obstetric Gynec Committee of Foxy. And Madam, thank you so much for joining us, and thank you so much for blessing us with your blessing, ma'am. Over to you, ma'am, for your words of wisdom.
Thank you. Thank you, Jairani. Thank you, Suman, for inviting me as a guest of honor for this prestigious webinar on midlife reproductive health issues. And both of you are my favorite. So I wish you all the best for the forthcoming elections before I say anything. And respected PC sir, you are the pride of the East Zone. Dr. Rajat Mohanty sir, another legend from East Zone, Meena, Supriya, Jairani, Suman, and all others who are present here. I wish you all a very good evening. And Jairani and Suman and all the societies of Odisha, Bihar, and South India have done a great job in organizing this webinar. And I wish all the best to this webinar. Thank you so much.
Thank you, madam. Thank you. Thank you for your kind words.
I always remember the fragrance of jasmine. Okay. Whenever I see Jairani. Okay.
Thank you, ma'am. Thank you, ma'am.
Thank you so much.
Thank you, ma'am. Thank you so much, ma'am. And it has been a great honor for us to have you here, ma'am, in midst of all the senior faculties here, Dr. Meena Saman, Dr. Supriya, Dr. M.G. Dhanlashmi from our side, and Dr. Chitra from our side, and also all the senior faculties, Dr. Sujata Kumari, and also Dr. Vinita Singh, Dr. Deepa, Dr. Leena Barua, Dr. Indra Palo, with all their expertise and knowledge for sharing their time on this Sunday evening. I welcome you one and all for this wonderful webinar. Over to you, Akila, for the
Yes, ma'am.
academic session.
Yeah, we start the academic session. Now I invite Dr. Meena Sambat, who's the senior consultant and head of the department. Madam is the president, Partner Obstetric Society. She's a vice president, ISOPAP. Madam is a chairperson, FOXY, and she has, to her credit, Kamni Rao Oration. She's organizing secretary in Yuva FOXY and organizing secretary in
Thank you, madam. Thank you.
DNB teacher, and madam has published many papers in reputed journals and chapters and book.
Akila, you have to introduce the
Thank you.
chairpersons, ma. Chairpersons, you have to introduce the first session chairperson. Dr. Arun
Yes,
Kumar
ma'am.
Singh, Dr. Sashmita Swain. Please introduce.
Yes, ma'am. The previous slide, please, Chitra. Dr. Arun sir. For the first scientific session, which is on bone and muscle mass, we have our chairpersons. Can I have their slides, please, Chitra?
There is there, Akila. Arun Kumar Singh. Yeah.
Yeah,
The previous one, ma.
previous one, ma.
Yeah. Yes, can you see that?
Is a renowned obstetrics and gynecology. And the next slide, please. The next chairperson is.
Sir is the secretary from the North Orissa Society.
Yes.
Yes, ma'am.
We have Dr. Sasmita's son. Madam is a professor, unit and department of obstetrics and gynecology.
Become muted. Unmute Dr.
Yeah.
Akila.
You are muted, ma.
Good evening, everybody. It is a pleasure to be part of this prestigious webinar where we have our very own Purna sir with us and also the senior members. And
genetics.
yes, and
I request you to introduce Dr. Meena, who's the speaker of this session.
she has already introduced, and we are all waiting to listen from on.
Yes.
Thank
you, madam.
Thank
Over
you.
to you,
Thank you. Yeah, I would like to share my
Yes.
slides. Yeah.
Yes.
Respected Dr. E.C. Mahapatra sir, Dr. Mohanty, I had a privilege to work under him while I was the chairperson of the clinical research committee, and it was an absolute pleasure because he was always there to help and guide. And thank you, Dr. Jay Rani Kamraj, Dr. Suman, and all the organizers who have given me this opportunity to be here amongst you. And the task that I have been given is to talk on building. Are my slides visible?
Yes.
Yes, ma'am. Please make it full screen, ma'am.
Is building bone and muscle health. Aging, they say, is mandatory, but sarcopenia and osteoporosis are optional. So by building healthy bones and muscles, we can avoid that. Basically, osteoporosis is characterized by low bone mass and microarchitectural deterioration of the bone tissue, leading to enhanced bone fragility and increased risk of bone fractures with little or even no trauma. And sarcopenia, that is poverty of flesh. There is loss of muscle mass, loss of muscle strength, loss of muscle function. It is a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength, and it is strictly correlated with physical disability, poor quality of life, and even death. We can say osteosarcopenia, that is bone and muscles. They are like brothers in arms, one helping the other, one harming the loss of one leading to the loss of the other. Osteoporosis, there is decreased bone mass and there is decreased bone strength. And in sarcopenia, there is decreased muscle mass, decreased muscle function, increased risk of fall, all these leading to increased risk of fractures. Osteoporosis can cause post-fracture pain, loss of mobility, changed body image, loss of independence, strong effects on self-esteem and mood. Dental disease, tooth loss may be an indicator of osteoporosis. The relative risk of mortality after vertebral fracture is as high as with hip fracture. And we know how age and bone remodeling go hand in hand. Estrogen affects the osteoblast to cause formation, and it also decreases bone resorption by acting on the osteoclast. However, when there is estrogen deficiency, there is increased osteoblast apoptosis and there is increased bone resorption. So bone loss accelerates substantially in the late perimenopausal and continues at a similar pace in the early menopausal years. And reduced estrogen action on osteoclasts lead to decrease in critical bone mass. There is trabecular perforation, loss of connectivity, and connective tissue, reduced ability of the osteoblast progenitors. So here, as we see, the women reach their peak bone mass around the age of 30. There is plateau, and then as the menopause appears and there's a low estrogen, there's accelerated bone mass. Now, this table is showing the some studies done in the Indian women, and all of these studies, be it in Mumbai, be it in Hyderabad, Jammu and Haryana, rural or urban, they all have shown the prevalence of osteopenia is pretty high, maybe 34%, maybe 36%. This is osteopenia, and osteoporosis can be anything between 8%. Here it is 29%, 20% in the Jammu study, 62% in the Delhi and Haryana rural areas, and 41% in Kerala. So what we know that it is pretty high. And we have to assess. I mean, like I was listening to one of these, they said, I mean, after a certain age, you do not even have to go for risk factors, but you have to take that patient is going to be become by and by osteoporotic with age, because it's also a part of aging. But as we know that FRAX is the online risk assessment tool with a 10-year probability risk. So we are taking into account the age, sex, weight, height, previous fracture, parental history of hip fractures, tobacco smoking, use of glucocorticoids, rheumatoid arthritis, alcohol intake, secondary osteoporosis, femoral neck BMD if available. And of course, the other risk factors, the excess, the mnemonics they have used is alcohol use, corticosteroid, calcium, estrogen, low smoking, and sedentary life. Some of these can be managed with lifestyle modifications. So to diagnose osteoporosis in postmenopausal women, we have a BMD T-score by DEXA of -2.5 or lower in the lumbar spine or proximal femur. While history of vertebral, that is spine or hip fracture, if it is there, then irrespective of BMD or other, we need not go in for that. We know she is osteoporotic. And if the bone mass, the T-score is between -1 and -2.5, with any of these, we have to classify her as a osteoporotic lady. History of fracture proximal humerus, pelvis or distal arm, or the history of multiple fractures other sides, excluding face, feet and hands, and increased fracture risk using the FRAX, but it has to be country-specific thresholds. Let's look at sarcopenia. Now, beyond 20 years, there is 3.3 to 5% loss per decade. And by the age of 60 years, there is 17.5% prevalence in Indian context. So why it happens? Again, there is sedentary lifestyle, poor nutrition, Acute and chronic comorbidities contribute to the development of sarcopenia in older persons because here there is reduced physical activity, generation of pro-inflammatory cytokines. And to diagnose sarcopenia, there is presence of low skeletal muscle mass and either low muscle strength, which is by hand grip, or low poor muscle performance. That is the speed of walking, it diminishes, the muscle strength power decreases. When all these are present, like first and either of the two is sarcopenia, but when all three are present, we classify it as severe sarcopenia. But then ultimately, we have to build the bone mass. And how we go about doing that, there are certain things to avoid. Smoking, yes, it's the incidence is rising in our country too, both active and passive. So we have to make a note of it. Alcohol, steroids, junk food, carbonated drinks that we are so fond of, and of course being a couch potato. Everything in this list has to be avoided. We have to love our bones. We have to protect them for our future. Now, with all these mutual funds and all coming, we know that early investments pay greatest dividends. So peak bone mass achieved in youth is the strongest predictor of later life skeletal health. Then let's look at the sunlight. Sensible sun exposure. And it is said that usually 10 to 15 minutes of exposure of the arms and legs or hands, arms and face 2 to 3 times a week. The afternoon sun between 10 a.m. to 3 p.m., which is most apt for the synthesis of vitamin D from skin of the human body. And for this, exposed area of the skin has to be free from any topical sun blocking or any other agents, so that there can be the best outcome of this exposure. So let's all be the sunshine girls. We also have to eat right. A healthy dietary pattern during adulthood is characterized by greater intake of low-fat milk and yogurts, whole grain bread and breakfast cereals, fruits and vegetables, lower intake of sugar, sweets, salt, processed food, and animal fats. Specifically, calcium intake should be extensively linked to bone health throughout life, and other vitamins like the K and E. They're also implicated for the bone health. A healthier diet in later life, especially in later life, is associated with lower risk of decline in the physical performance of older adults. So in the diet, a high protein intake is associated with greater muscle mass and strength. Protein intake of more than 0.8 grams per kg or 24% of the total energy intake that is desirable. So this was one study that I was looking at, and it says like leucine is important, but just taking leucine is not good enough. It has to be a combination of nutritional supplements, because we know when we assimilate the food, so many enzymes, coenzymes, and all those are required. So it has to be a balanced diet at the end of the day. Then calcium. Calcium absorption, it actually decreases with age. A positive calcium balance is needed for the prevention of osteoporosis. A daily requirement of 1000 milligrams is needed if patient is on estrogen, if she's having her own estrogens or supplemented. But the daily calcium requirement would be 1500 grams if she's not on estrogen. Calcium intake in adolescence is important for bone density and skeletal mass for later years, as we already saw that the highest density accumulation occurs in the early ages. Calcium intake should be achieved principally through diet rather than the pharmacological agents. Now, we have seen that we Indians are very low in vitamin D. As such, maybe because of our color, our diets, our health. So given the low levels of vitamin D in Indians and absence of fortification, the appropriate daily intake of 1000 to 2000 is considered safe. Frequency of dosing may not matter as much as the total dose administered over time. However, recent evidence suggests intermittent dosing may not be the best. Now, having said that, parenteral vitamin D should be avoided. Rather, what I mean to say is it should not be the first line treatment because it can cause a lot of hypervitaminosis. Now, coming to insulin resistance, obesity and sarcopenia may potentiate each other and act synergistically, causing physical impairment and metabolic disorders and mortality. Aging is often associated with chronic inflammatory conditions such as obesity, atherosclerosis, type 2 diabetes, and insulin resistance. In older women, older individuals, skeletal muscle protein synthesis is resistant to the anabolic action of insulin. However, insulin resistance may be associated with, therefore, this insulin resistance may be associated with age-related muscle loss. So we have to remember that obesity itself is a pro-inflammatory condition and causes a lot of insulin resistance. So this is where we can actually hit out. So weight matters. Increases in visceral fat may lead to augmented secretion of pro-inflammatory cytokines that may promote a catabolic effect on the muscles as well as insulin resistance. So we have to stop this inflammation because a lot of our health issues are related to this. We have to be active. There is an important correlation between inactivity and losses of muscle mass and strength. This suggests that physical activity should be a protective factor for prevention, but also the management of sarcopenia and bone health. Now, sedentary behavior has been shown to have a negative impact on bone health. There is lack of muscle activation and unloading of the bone structures. The frequency of osteogenic activities rather than volume of physical activity appears more important. High impact sport activities associated with higher levels of bone turnover in females. The vertical accelerations and moderate vigorous physical activity independently predict bone properties, especially at the weight-bearing sites such as tibia in older women, men and women. So coming to the muscle building. So like they say, good things come to those who wait, but better things come to those who work for it. And we have to work for our muscle building. So resistant exercises are good for us. Partial squats, sit and stand, overhead tricep curls, lunges, leg raise. So for the beginners, 5 to 10 repeats would be good enough. For the regulars, 10 to 15 repeats and 5 to 10 sets, 3 to 5 days a week. That should come into our routine. And we have the lifting of weights, stretching, yoga sessions. All these help in improving our posture, the balance. They prevent falls, they prevent osteopenia, build high aerobic capacity, and prevent collagen loss, and put metabolically active muscles on our frame. And actually, we ultimately want to do the best for our bones and muscle, whatever way we do. Some of us may find dance exercise doing better for us. So anything that we do is good enough. Coming to the pharmacotherapy. Pharmacotherapy would be needed by many, but all the other things in prevention and building a bone mass and the bones and muscle mass have to be there because all these will act better when other things are in place. So when we are talking about prevention and treatment, bisphosphonates and SERMs, they act both in prevention and treatment. But when we have a treatment in our mind, we would be looking at recombinant parathormones and monoclonal antibodies to rancor, that is denosumab. Anti-resorptive agents we have are the estrogens, the selective estrogen receptor modulators, bisphosphonates, denosumab, calcitonin, and vitamin D. Anabolic agent we have recombinant parathormone, that is teriparatide. So let us look at the hormone therapy. The HOPE trial, according to that, the dose of 0.3 milligram of conjugated estrogen would be good. Any increment in the estrogen would only exert a protective and a positive effect on the bones. So it should be considered at an early stage, early menopause with low bone mineral density. In the long-term use, periodic assessment and timely adoption of risk reduction strategies, that is transdermal use, lower dose. Testosterone should not be prescribed for this indication, and follow up BMD when women in late 60s, because we know there are certain concerns regarding the estrogens, prolonged use of estrogens. Now, regarding the role of MHT in postmenopausal estrogen, according to AAC's 2016, menopausal hormone therapy is effective for prevention of postmenopausal osteoporosis. But when prescribing solely for prevention of postmenopausal osteoporosis, therapy should only be considered for women at significant risk of osteoporosis when non-estrogen medications are not considered to be appropriate. Because we do know that estrogen we are giving based on the age and the symptomatology, and most important for that is the hot flushes and the vaginal symptoms, the genitourinary symptoms. So in symptomatic, but in solely for prevention of osteoporosis, these are things that we have to remember. According to the Endocrine Society 2019, it is used for prevention of all types of fractures in postmenopausal women at high risk of fracture, and the following characteristics, that is under age of 60 years or less than 10 years post-menopause. Those in whom bisphosphonates or denosumab are not appropriate, and when of course they are along with bothersome vasomotor symptoms and without any contraindications. So let us look at the selective estrogen receptor modulators. We have raloxifene, the prevention option when enhanced risk of breast cancer. So when we are talking, we are thinking of there's a risk of spinal fractures, and also there's a risk of breast cancer, because we know these terms have a protective action in the breast. So these would be more ideal, suited for raloxifene also, but it has no evidence of reduction in the hip and risk factors. It is an option for treatment of postmenopausal osteoporosis in women with low risk of hip fractures, elevated risk of breast cancer, and low risk of stroke and VT. So we know that it can cause some vasomotor symptoms. Now, a combination of estrogen and bacidoxifene, I think it's still not available here. It is approved for osteoporosis prevention in postmenopausal women with uterus. Then we have tibolone. Tibolone metabolites have estrogenic, progestogenic, and androgenic activities. Tibolone preserves bone mineral density, reduces hot flushes, and may increase libido and vaginal lubrication. So many women would be looking at all these beneficial effects. So daily dose of 2.5 milligram tibolone is the dose. Some evidence also suggests that as low as 1.25 milligram as well as 2.5 orally per day may be effective in preventing loss of bone mass. But it should be avoided early with the risk of stroke. Bisphosphonates They act by enhancing the osteoclastic apoptosis prior diagnostic screening with lab tests to exclude secondary causes. So it can be used for a long time, but drug holiday would be needed after 5 years, and longer treatment in only high risk. Those with high risk, then only we would go for that. So there are so many drugs: alendronate, residronate, abendronate, zoldronic acid. So depending on the dose, it could be a daily, weekly, monthly, even 6 monthly, and so on. And they may have some adverse effects like upper GI adverse events in oral bisphosphonates. They may be renal toxicity, influenza-like illness, osteonecrosis of jaw, uveitis, atrial fibrillation. All these have been reported, so we have to monitor for these and look out for these. There are some other therapeutic drugs in use. The denosumab, that is 60 milligram. It is given subcutaneously every 6 months. Women with postmenopausal osteoporosis, including at risk of vertebral and hip. There is no limit to the duration of denosumab therapy, and subsequent therapy to prevent bone loss and vertebral fracture should be started by 6 to 7 if we've given a break. Calcitonin nasal spray. Now, teriparatide, that is 20 milligrams subcutaneous daily. Women at a very high risk of fractures, those with prior and especially recent fractures, very low BMD, T-score between -3, below -3, and those who sustain fractures or lose BMD while taking anti-remodeling therapy. Recently, I had a lady who had a fracture and she was on bed rest for a long time. And now she has severe osteoporosis, severe bone pains, and she's taking this drug. And she's in her 30s, late 30s. She wants to conceive, and she wanted to know if she conceive. And yes, she cannot with that while she's still taking the drugs. But at present, her priority is her bone pains. So I think she will come back after a few months. So increase bone mass rapidly and reduces bone risk more effectively. It should be followed by anti-remodeling agents to maintain bone density gains. So that brings me to the conclusion of my talk. Osteoporosis and sarcopenia are common conditions in postmenopausal women. Management of skeletal and muscular health in postmenopausal women involves assessing the risk factor, reducing modifiable risk factors through dietary and lifestyle changes, and the use of pharmacological therapy for patients at significant risk of osteoporosis or fracture. For women with osteoporosis, lifelong management is necessary, which is multidisciplinary, and treatment disciplines occur continuously over the lifespan of a woman. Decisions must be and should include the patient in the process of shared decision making. So thank you, my very respected chairpersons. Thank you for chairing my session.
Thank you, Dr. Minna. It was a very excellent deliberation. You described everything from building bone, muscle, and pharmacotherapy, recent drugs, everything was done. So thank you, congratulations to you. And my best wishes to Dr. Shuman and also to Dr. Jairani for the forthcoming election. Hope for the best. And unitedly, we must work to make the Foxy stronger and stronger, whatever may be the result. That is our aim. Thank you.
Thank you, madam. Thank you for your inspirational words. We'll definitely, we will take up your words and we'll work for it, madam. Meena, that was a very amazing talk, and really every part of it are crystal clear with a good, effective way to, which is an eye opener for many of the postmenopausal women. Thank you so much for your time and sharing your knowledge on this. Thank you so much.
Meena, you had a very nice presentation.
Yeah.
I'd like to ask one question. Do you agree that we all should continue with the vitamin D supplement after taking the full course? Full course is of, say, 8 weeks, right?
Yes.
But do you advise that it should be taken every month?
Yes, because like I did point out, Our diets are very deficient and we are prone to vitamin D
We
deficiency.
have to
because
be a
of the
sunshine
temperature.
lady, as Dr. Meena told. We have to be a sunshine lady. Yeah.
Yes,
Then
and yes,
only we can do this.
supplementation.
Yeah,
Supplementation.
sun exposure should be done.
Because, when I tell my patient that I've given you this tablet, take it for every week for 8 weeks. And then 8 weeks or 6 weeks. Then whenever I ask them that you continue it every month, at least one tablet, they say, no, I've completed my course. I don't know from where they have got this, that I should not take. So,
Madam, now what the calciums that we are giving, they also come with some added vitamins, vitamin D with that.
yes, it is. But when you give calcium for a very long time, they say, I don't know from where that it will cause renal stone, it will cause gallstone, and then they leave. But they don't know that what is going to happen when they reach after 65. They will start having sarcopenia and osteoporosis, definitely. So it is a very, vital topic to be discussed on and on. Thank you, Meena, for enlightening us on this very vital topic.
Thank you, madam, for the elaborate talk on building bone and muscle health. Now we move on to the next session. We have Dr. Deepa to talk about the midlife crisis. The chairpersons, I welcome the chairpersons, Dr. Kalyani Singh and Dr. Vinita Singh. Can I have madam's slide, please? Yes, madam is associate professor in LBKMCH. She's a senior consultant and gynecologist in Shastra Hospital and PK Hospital. Next slide, please. Next, we have our chairperson, Dr. Vinita Singh. Madam is associate professor in the Department of OBGYN in Patna. She's a consultant in Care Hospital and IVF Center. At present, she is holding the post of President, Patna Obstetric and conducted many workshops and conferences. She is a winner of MG Mishra Award 2004 and George Monet Award in 2012. Over to you, madam. I request you to welcome Dr. Deepa. Madam, can you introduce Dr. Deepa, ma'am, chairperson? Ma'am?
Yes.
Yeah, madam is there. Yeah. Madam is
Yes,
there.
ma'am.
Yes. So,
Can you introduce the speaker, Dr. Deepa, ma'am?
Yeah, she's doing.
yes. Okay.
Yes, ma'am.
Thank
you, ma'am.
Should I introduce?
Ma'am. Yes, ma'am. Please,
Yes,
ma'am.
ma'am.
Okay. So, first of all, thanks especially to Dr. Jayarani and Dr. Suman for inviting me on this prestigious webinar. Lots of thanks. And now I am going to introduce Dr. Deepa Thang Mani, MD. At present, she is Joint Secretary, ATNRCOG, the Association of Tamil Nadu Members of Royal College of Obstetrician and Gynecologist. She is Joint Secretary of Chennai Menopause Society, Advisory Committee of the 2023, the Obstetric and Gynecological Society of Southern India. Her area of interest is gynecoscopy, emergency obstetrics, and intrapartum care, and ART. Her achievements are presented many papers and posters in international conferences and world congress, given many invited lectures in national and state conferences, written a chapter on toxicology and pregnancy in the textbook of medicine, coordinated and organized many clinical meetings and skill workshops under ATN-RCOG, coordinated MRCOG teaching programs, coordinated CTG workshop. Clinical examiner for Part 3 MRCOG since 2019, member of OXI, OGSSI, ATN, RCOG, IMA, CMS, IAGE, ISOPAR, SOPSI, AOGIN. Past member representative AICC, RCOG, South Zone, Indian Representative Council, London 2011 to 2019.
Thank you so much, ma'am. Thank you, Kalyani madam. At the outset, I'll thank Jairani madam and Dr. Suman madam for giving me this opportunity. And my topic given today is midlife crisis. So this is a topic given to me. And See, midlife crisis, we know what happened after menopause. After menopause, you have a lot of changes happen. But it is a transitional period. The road to menopause, we have a MT is menopausal transition, and early menopausal transition, and late menopausal transition. But during this period, there is a lot of fluctuations of hormones. Because of that, there will be a skipped cycles, prolonged amenorrhea, and the same fluctuation will causes our menopausal symptoms, perimenopausal symptoms, which happen in the climacteric phase. Previously, we called that as a climacteric phase. This is a stage, reproductive staging of women through the menopausal age groups, or perimenopausal age group. I would like to concentrate only in the early menopausal transition, late menopausal transition, early postmenopausal, and late postmenopausal. So this early menopausal transition, we don't know how long it will vary. It will be there. So it varies. But late menopausal transition is strictly between 1 to 3 years, and early postmenopausal period is 2 to 6 years, and late postmenopausal period is more than 6 years. So what happened in the early menopausal transition, you have a skipped cycles, and there will be a change in the pattern. And late menopausal transitions, amenorrhea more than 60 days, and you don't have a periods. That's why we call it menopause. And the supporting criteria in early menopausal transition, it has been found that there is an FSH is rising, and there will be a variable AMH, and inhibin and AFC will be low. In late menopausal transition, the FSH is very high, to going to 25. AMH, inhibin, AFC all are started declining. And post-menopausal age group, the FSH becomes stabilizes, but all your inhibin and the AMH will be very low. So these are the symptoms we have to note down. Your hot flushes is the most frequent. 85% of people will started getting hot flushes in their transition periods compared to the postmenopausal, though it has a long-term, long persistence for some people for long-term. And late postmenopausal period, that is more than 6 years, you started having the vaginal atrophy. So these are the symptoms. These are the symptoms we can go for a hormonal therapy. That's the reason I restricted these symptoms into hot flushes and vaginal atrophy. So the clinical correlation and progression is your hormone levels will be more erratic and cycle shorter, and PMS increases prior to skipped cycles, the perimenopausal symptoms. Okay, so symptom associated with early menopausal, the first and most common, 65% of premenopausal have hot flushes. It began to increase in frequency or appear for the first time. Because of hot flushes, your sleep gets worsened, and this sleep insomnia, the lack of sleep will causes your long-term consequences like increased aortic calcification and greater risk of metabolic issues, increased BMI, increased hypertension. Your headaches will become worsens, and you will be most of the days will be irritable, and dysphoric moods increases. So these are the core 4 symptoms attributable to menopause to be relieved by the hormones. Hot flushes, 85% of perimenopausal age group will be having hot flushes. Adverse mood and depression in 30% of people. 60% have poor sleep, insomnia, and 40 will be having a vaginal dryness. We will start with hot flushes. Number 1. What is hot flushes? It's a spontaneous sensation of warmth, usually felt in the upper part of the body, followed by the cold sweats, night sweats. It variable in increase. Each episode will be variable in increase frequency, duration, and severity. Each episode usually lasts around 2 to 5 minutes. It can be triggered by your warm environment, hot drink, or emotional stress. Even when you are in AC, if you have stressed out, then you can feel the hot flushes. So the hot flushes is the most common reason these women seek care at the time of menopausal transition. So when do they start? As I said, it started premenopausal. 22 to 68% of hot flushes started premenopausal. Regularly cycling women also report hot flushes. Prevalence varies several fold by the ethnicity. So if you are like Native Americans or Africans, you have high Mayan, you have a high prevalence of hot flushes compared to Japanese and Chinese. So prevalence increases as a woman enters and traverses the transition period. The peak prevalence spans the year before and year after the final menstrual period. So as I said, the ethnicities, your Native Americans, Black, white will be having higher compared to the Chinese, East Indians and Japanese, which will be having a reduced heart incidence of heart flushes. So other factors influencing heart flushes other than ethnicity, your BMA. BMA, so heart flushes is worse in obese women before the final menstrual period, but the same obesity for some people, it may be protective after the postmenopausal age group. So anxiety, and if you have anxiety and depression, it again versus, it is a cyclical interchange. So again versus a heart flushes. If you have a higher FSH, low estradiol, and you will be having a worse heart flushes. So what is the, how long it will heart flushes last? So there's a parents ovarian aging study shows if your heart flushes happens to you before the age of 44 or very early in the menopausal transitions, more likely to last for 10 years or longer. And it could be very severe. So earlier start is a worse prognosis. Black women with a BMI of 30, even less than 30, have a longest duration, 12 years of heart flushes. If BMI is more than 30, heart flush duration is overall shorter because initially it will come faster and then they appear the late transitions, the heart flushes disappears. In BMI, in obese people, severe heart flush durations lowest in Caucasian women with the onset of more than 44 in late transitions, which is about less than 2 years. So obese people, after menopause, it gives some protections. They will last only 3 years. Next symptoms will go into the menopausal depressive symptoms. You will be depressed. See, there will be an interchange. So estrogen withdrawal causes hot flushes and menopausal depression. Both will cause insomnia. So it is all interchange. So hot flushes, night sweats, vaginal dryness, with your depression, irritability, and thoughts of death, worthlessness, reduces the energy, reduces the concentration, reduces the sleep, and there will be a late change, low libido. So it is a cyclical thing. So this happens even in the transitional period itself. So major depressions, the SWAN study observed 8.6% of women years of observation is SWAN. Major depression and menopausal transition occur in a woman who have a prior major depression. If they have a very stressful life events, if they use any psychotropic medication, even before they are going into the transition period, peri and post-menopause compared to pre-menopause. If you are a Japanese or Hispanic, then your mood swings and depressions is very high. So this is the same staging of reproductive age group staging of the woman. So the menopausal transition, there will be a fluctuation starts, and after final menstrual period, there will be a total dryness, total estrogen deficiency. So there will be a hormonal fluctuation time. You will be having lots of mood swings. So it is very difficult because the strongest predictor is like because of the fluctuation. If you have a prior fluctuation happen after post delivery, there will be a dryness of hormones and there will be a fluctuations. If you have gone through a post pregnancy depression, then you have a high risk of getting it. Same thing if you have a PMS every month before periods, during the luteal phase fluctuation of hormones, if you develop depression, then you have a high risk of having a depressed mood during the postmenopausal age group. So this study says, if there is a study says the late peri and pre-menopause, post-menopausal age group, the odds ratio is very high. You will develop you are high in favor of depression in late peri and post-menopausal age groups. On top of it, life stressors. So that was the age group you will be having a look. There will be employment issues, or your career growth won't be much, or lack of social supports, or you already underwent a surgical menopause because of any gynecological issues, poor overall health status. Your social roles and expectation may contribute to the heightened rate of depression. And if you have a negative mood before menopause, your attitude towards menopause will be, if you have a negative attitude towards menopause, and if you're smoking, if your physical activity is very less, if you're a single woman, or if you lost your husband for some other, in the course of this, because of aging or some comorbidity, poor self-perceived health, your children will be you will feel loneliness, because by the time your children will be entering into the college, or they will get married, and you started having negative feelings towards a partner, and interpersonal stress, and you have another burden like caring of your aging parents. These are the life stressors on during this periods will increases the mood issues. So this is the just to show estrogen deficient causes are the things. So estrogen therapy is the answer for all your sleep problems. I'll discuss the treatment later on. So the third problem we will be having is a genitourinary syndrome of menopause. Previously we called as a vulvovaginal atrophy. So this is now enter into the common entry, like if you have a recurrent UTI, pruritus, bleeding, vaginal dryness, dyspareunia, urgency, all coming into this GSM group. While on examinations, they will be having introital narrowing, loss of labial minor tissue, and they will be having some pigmentation. Vagina will be shortened, loss of mucosal rugal folds in the vagina, small petechiae, easily friable and dry, and there will be an elevated vaginal pH. Unlike vasomotor symptoms, genital atrophy worsens over the time. So if you're not initiated the treatment, that it will worsen, it won't come back, it won't be reversed with the estrogen. So for them, there will be a longer duration of treatment is often appropriate. So GSM, if you include with 20, it's affecting that around 40% on average women will get affected. It was not well studied longitudinally, and it is a late onset. Symptoms worse in the later part of the menopausal transitions, and as the older age goes, it will worsen, and if treatment is not initiated, it will further worsen. It is usually underrated because they won't come with this complaint. They ignore, most of the women ignore this GSM issues. And with that 4 core symptoms, now we move on to what are the common problems that cause health compromise in midlife or aging woman. In the midlife period, that is in the transition period before going into the menopause, the first more common is a metabolic syndrome. So metabolic syndrome, and second is a coronary heart disease. It happens to start rising from your midline to old age, and same during the midlife to old age, you have a cancers of lung, colon, breast, ovary, and endometrium. Older age, you have a osteoporosis and fracture. Madam has detailed discussed with this. So first, we'll go with the dysmetabolism. What does the SWAN says? SWAN says 6% of women enter into the perimenopausal crisis with a baseline metabolic problem. So by the end of your final menstrual period, they 13.7% had new onset metabolic syndrome. This is related to the free testosterone index. So those who are already obese, but they are metabolically benign obesity, they progress quickly into the at-risk obesity in 43% of times over the next 7 years. So higher BMI and impaired FBS were biggest risk for progression. And the most common mitigating factor is lack of physical activity. So you have to be more physical to reduce this dysmetabolisms. And finally, on top of it, the depression, childhood abuse influences the dysmetabolism. Now move on to the second long-term health consequences is a coronary heart disease. Coronary calcium, the CIMT, is a corrected intimal media thickness, are typically low in eumenoric women until the menopausal transition. With the onset of transition, the corrected intimal media thickness begins to increase. So women already at risk of metabolic syndromes increase the CMT and adventitial thickness factor linked to serum hormone binding globulin. Cardiac fat also associated with the subclinical coronary vascular disease, and the strong intermediate risk markers for the atherosclerosis is a CAPMT and cardiac fat. The lipoprotein change adversely affect in association with the menopausal transition. So these are the reasons you started getting your old age, as the age increases, post-menopausal age group, you will start having a coronary heart disease. And cancer risk. So there will be a linkage of in the midlife to old age. In commonly, there will be a risk of breast, colon, ovary, endometrial cancer to hormones. Probably it is those cancers are linked stronger to the genetics, but linkage to the hormones is also there. So it is very difficult to predict with brief hormone exposures or deviation from the normal, which causes what? So OCP in the younger age group is protective against ovarian cancer, but menopausal hormone therapy, the estrogen alone arm increases the risk of ovarian cancer. As such, early menarche and late menopause also have a breast ovarian cancer risk, perinatal cancer risk high. Finally, coming into the osteoporosis, I'm not going into detail. If you see the picture in the premenopausal age group, there is osteoporosis. There is strongly your bone mineral density is absolutely normal. And the early menopausal age group, only in the lumbar spine, there will be some kind of osteoporosis, osteopenia started. But in late perimenopause and postmenopausal growth, both total hip and lumbar spine, you started developing an osteoporosis. So it is a estrogen related bone mineral loss. Would you like to screen? The American, the International Society says you have to 15 years after menopause only ask us to screen. But Indian Menopause Society says for 5 years post-menopause, they are eligible for screening if they have other additional risk factors like family history of any fractures, family history of osteoporosis, or if they have a secondary causes of any osteoporosis, or if they are genetically prone, then we have to screen them so that we can act on we can protect the bones. Rapid bone loss over the approximately first 5 years there is a rapid decline, so we have to screen them. This may not hold true for all women. So how to identify those at risk? So the risk is, these are the risk. Main is physical activity, nutrition, sunlight exposures, relevance, which are all modifiable risk factors. So you have to increase the calcium intake, do the physical activity, expose to sunlight, and when as the age increases, you have to do falling prevention program. Modifiable risk factors, again, low BMI, smoking, and more than 3 drinks of alcohol per day. Gender, advancing age, prior fragility factors, and family history of fractures, we can't modify. So dementia, long-term risk, major cause of morbidity and mortality in elderly women is dementia. Hormonal risk factors have long been solved, but there is no evidence that hormones, whether it is an exogenous or endogenous exposure, has a risk in naturally menopausal women. But having said, surgical menopause, those who have had a surgical menopause, early menopause, because of the surgery, their studies have found out they have a risk of getting dementia earlier. RCT of hormone therapy failed to confirm benefits seen in observation. So hormone therapy for the dementia, for the treatment of dementia or prevention of dementia, hormone therapy has failed to confirm any benefits. So now come to the management. So after the WHO, which was released in 2002, we stopped giving the menopausal hormone therapy for all the women. So the practical issues is like, but the 4 core symptoms like hot flushes, mood swings, sleep, all are interlinked. They are eligible. If they have coming with a symptomic, they are eligible for hormonal for a short term, short duration. So the practical issues is like non-hormonal, and now all the companies or media has like bioidentical, compounded bioidentical hormone therapy, then hormone therapy with the SERM, transdermal with oral estradiol, and for GSM vaginal. How long we have to use? It depends upon the symptom. If the symptom needed, if they were needed, we have to use it for a longer time, because those who are having a symptoms have a high risk of cardiovascular long-term metabolic syndrome. So estrogen will benefit. So less than 60 years, if they are really symptomatic, where HRT will be for hormone therapy will be the first option. So non-hormonal, because of the WHO only, the decline use of hormone therapy, we switch over to the non-hormonal therapy. Nonetheless, the following, the many clinicians remain reluctant to treat even with the bothersome menopausal symptoms. So many symptomatic women are not treated. So more women and clinicians are interested in non-hormonal, but we need a better quality trials for the non-hormonal things. So non-hormonal, non-prescriptions, what are the treatment options? They can be prescribed with, they can be given without any prescriptions. One is soy extract, isoflavone, black cohosh, Chinese herbs. But compared to hormone therapy, none of these have any benefit more effective than the placebo. So in trials comparing, we need further trials comparing that non-prescriptions drugs, not plant estrogens. So what are the prescription non-hormonal medications? we have lots of like gabapentin, SSRI, SNRI, gabapentin, pregabalin, and newer drugs have been found. But until 2013, all these non-hormonal medication used for heart flushes are off-label. So after 2013 only, they slowly they have given, we can use these kind of medications for the purpose of heart flushes. So they are compared to hormone therapy, these medications are less effective, but compared to placebo, they are much more effective. So in SSRI is an antidepressant, paroxetine is best studied. In SNRI, venlafaxine and desvenlafaxine has been studied, and the duloxetine, which you give as stress incontinence, will also studied for heart flushes, and gabapentin and pregabalin. If you have especially night sweats, pregabalin, which disturbs the sleep, the gabapentin will be having a first choice. The side effects of these drugs is different from that of hormone therapy. So coming to SSRI paroxetines, it's a fixed dose. We have to give a low dose 7.5 gram, more effective than placebo and reducing the frequency of heart flushes. So people, if they take paroxetines, they will be having 1 to 2 fewer heart flushes per day when compared to the placebo. But side effects more common with the active drugs. What are the side effects? You will be having nausea, fatigue, dizziness. Sexual side effects are more or less equivalent to placebo. So as I already says, FDA is not approved. After 2013 only we have approved. So there is no need for tapering or no dose escalation is needed. This is like FDA is not really approved. Many media has used compounded bioidentical hormone therapy. It's nothing. They will be having some estradiol with other masalas in the oil capsules. So we really don't know, because the endometrial protections, how much it is that compounded bioidentical therapy, BHT. Many people will start coming and asking for bioidentical hormone therapy. So we still don't not use. So only the patches, micronized tablets, progesterone in oil capsules have been approved by the FDA. An alternative to estrogen progesterone is only the estrogen progesterone arm has been stopped when there is a uterus is present. The progesterone EPT has been stopped with WHA. So instead of progesterone, we can, as for the osteoporosis, as madam says, basidoxifene 20 milligram tablets. Here also hot flushes, we can give a low dose estrogen, primarin, as well as plus basidoxins to treat hot flushes and to prevent osteoporosis. And what are the contraindications and warning, which is similar to the conventional estrogen progesterone therapy. And in contrast to estrogen, it has a good effect on the breast. That is the reasons basidoxifene has been clubbed with the estrogens. It has been approved since 2013. And if you're still worried about the endometrium, its breast is okay, but for the endometrium, you can use an LNG IUD for breakthrough bleeding, to prevent the breakthrough bleeding. This is in nutshell we have given. Well, we are not treating any mild heart flushes. Only we are treating a moderate and severe with the drugs. So mild, you have to go for a behavior therapy. You use a heat-friendly clothing. You use a cooler fan. Lower the temperature of the rooms. Avoid the triggering factors like coffee, tea, alcohol, spicy foods. For moderate to severe therapy, if it is preliminary, now predominantly nocturnal, your first choice will be the gabapentin. If good response, you continue. But if it is a poor response, you have no other option. You have to go for a hormone therapy. So when you start a hormone therapy, you start the very lowest dose possible and adjust the dose as per response to treatment or side effect profile. If you have a highly metabolic syndrome risk patients or already comorbidities, it's a contraindicator of the patient not willing to use a hormone, then you can go for SSRI, SNRI. But if they have an SSRI, SNRI have a poor response, then you switch between one or two drugs in the same combinations. And if there is no contraindication, you can still go for HRT. If hormone therapy is good response, then you have start after 1 to 2 years, start reducing the dose. So while the patient is off medication, if they start having recurrence, then consider introduction of the HRT. And or you can go for SSRI, SNRI and come back to the hormone therapy. But more than 60 years, they are not eligible for hormone therapy. These are the few newer drugs. Fezolinetant, it's selective neurokinin 3 receptor antagonist that blocks NKB binding on the. This is a neuron in the hypothalamus. So if this drugs has a potential treatment of moderate severe VMS, If this drug has come, is another drug. We can come out. We can boldly. We don't have to use hormone therapy. So their studies are found out, but still it's in the trial. So coming to the treatment of GSM, first and foremost is behavioral. You have to stop smoking. You start your regular sexual activity. Non-hormonal vaginal therapy, you can use moisturizer and lubricants. Select systemic estrogen therapy. More than that, you start with local estrogens. You have creams, rings, and tablets. Start daily for 2 weeks, then twice weekly for 1 year. The 1 year is the period they have been studied. So progesterone production for endometrium is not needed. If they want to prolong use, then we have to give a protection for endometrium. Maybe you have a spotting or breakthrough bleeding, because the studies have found only 1 year of vaginal use with an intact uterus. You don't have to need a progesterone like LNG IUD or any additional progesterone is needed. It's improved GSMs, also reduces urgency UTIs. It minimizes and avoids the impact locally administered treatment. There are 2 new drugs for the GSM. One is the SERM, selective estrogen receptor blockers, aspimefin, 60 milligram. If the main complaint is dyspareunia, then this is a drug of choice. But the most common adverse effect of this is hot flushes. As I said, GSM happens late in the menopausal age group. By then, for some people, the hot flushes must have been gone. So you can separately you can use this without any issue. But additional side effect, they will be having a leukorrhea, muscle spasm. Its contraindication for a SERM is similar to estrogen. It may be an appeal to symptomatic GSM who don't want to use vaginal estrogens. The oral drugs will be better. As estrogens, it need an endometrial monitoring, particularly if you decided to use for the longer term. And there is another drug called brasterone. It is nothing a DHEA. It transformed to estrogen in the intracellular level. So thereby it was approved in 2016, but still not widely available. It's a single dose 6.5 milligram ovules, little impact on the serum estradiol level. In contrast to vaginal estrogen, those who are having a history of breast cancer not listed in is a contraindication. So vaginal estrogen, there is a breast cancer. If you have a breast cancer, vaginal estrogen is not contraindicated. But here it is not contraindicated in the patient information leaflets. So now how will you maintain the hormone therapy? As I said, hormone therapy can be safely given for the symptomatic. Start with the standard dose. But for obese smokers, women with CVD, VTE, consider transdermal patches. So these are the women we have to bypass the metabolism. You have to bypass the liver. So you have to opt for the vaginal route or transdermal route, better transdermal route. After hot flushes have resolved for several years on initial dose, encourage the patient to try a low dose. Then if the patient says, my hot flushes recurs and I'm not feeling all right with a lower dose, then you can go back to the higher dose. And if they are already using a low dose or ultra dose, then there is no hot flushes, you stop hormone therapy. Can continue if additional risk of osteoporosis is that. But if you start a hot flushes for the prevention of osteoporosis, once you stop hormone therapy for the osteoporosis treatment, once you stop the hormone therapy, the bone loss will be very drastic. So you have to be cautious in giving as a prevention aspect. With low dose GSM symptoms manifest, consider vaginal. So what is the take-home message for my talk? Your 5 core symptoms in the midlife crisis is your hot flushes, depression, sleep, GSM, 4 core symptoms. They need to be taken care. You cannot ignore that. If you have a hot flushes early in your 44 years, you have high risk of your cardiovascular morbidity. So non-hormonal prescription drugs may be the first options. If you are 60 and eligible for your hormonal and you have a severe, moderate to severe symptom, then you can go for a hormone therapy. GSM, you can go for vaginal. Do not start hormone therapy as a prevention for osteoporosis. Whenever you're starting, start as a very, very low dose. Very careful with the bioidentical hormone therapy. Thank you.
Thank you, Deepa ma'am, for the elaborate. Yes, am I audible?
Yes, ma'am.
Thank you, Deepa ma'am, for the elaborate discussion on middle age crisis.
Yes, sir.
Over to chairpersons, please. Dr. Kalyani ma'am. Next, thank you, Deepa ma'am.
Thank you.
Next session, we move on to the next session, which is everything about contraception. We have a panel discussion with the chairpersons. Yes, am I audible? We have our chairperson, Dr. Sudha Rani, Dr. Sujita Kumari, and Dr. Supriya Jaiswal. Dr. Sudha Rani, Madam is a senior consultant in obstetrics and gynecology. Next, we have Dr. Sujita Kumari. Madam is a consultant in Shanti Memorial Hospital. She's a renowned gynecologist and IVF specialist. Next, we have our Dr. Supriya Jaiswal ma'am, who's a vice president, partner, obstetrics and gynec society. Madam is a chairperson in Adolescent Health Committee. She's a joint secretary in Bihar and chapter. Madam is the chief consultant in SM Hospital Partner. Madam is
Thank you, Dr. Akila.
Post. Yes, ma'am. And Madam is a recipient of awards of MP John and Dr. GVLN Murthy Award for her paper presentation. She's a recipient of numerous awards and certificates. A special interest is high-risk pregnancy and preventive oncology. I request the chairpersons to introduce our moderators, Dr. Dhanlakshmi and Dr. Umaram. Over to you, madam.
Who else is there? So, okay. I will introduce Dr. M.G. Dhanlakshmi. Madam is Professor and Senior Consultant, Department of OBGY, Srihar, SRIHER, Executive Committee Member, OGSSI 2023, UG and PG teacher since 1995. Welcome, Madam. And Dr. Leena Baru, Associate Professor, ONG, Vimsar Burla. She is a trainer of CPCG, that's a certificate program in community health, and Council of Paramedical Science of India, Comprehensive Abortion Care. So, welcome, Madam. Dr. Indira Palo, she is the Associate Professor, MKCG Medical College, Secretary of Berhampur OBGY Society, and life member of FOXY, IMA, SAR, SFM, IAG, and Rotary. Secured first position in first MBBS and second best in final MBBS. She has published many articles in national journals, and she has published a book on immunization in pregnancy. Welcome, Dr. Indira Palo. And the other chairperson would like to introduce the others? Or it's me only? Okay. So Dr. Akila Ayyappan, Medical Officer, Greater Chennai Corporation. Welcome. Dr. E. Chitra, MD DGO, she is passed her MBBS in the year 1978, MD from Institute of OBGY Madras Medical College in the year 1994. She is the founder president of Obstetrics and Gynecology of Krishnagiri and Dharampuri district, and she was awarded Lifetime Achievement Award by the IMA Hazur. So welcome, Dr. E. Chitra, Madam. Dr. Kavita Badwal, she is senior consultant and laparoscopic surgeon, Samarpan Hospital, Munger, recipient of Padma Bhushan Kamlabai Hospital Award, member YTP Committee Foxy in 21-23. She had been the organizing secretary of 9th AOGS BJ, life member of so many societies and trained in IVF, and she has also contributed many chapters in new books, new molecules, conducted more than 7,000 laparoscopic ligation in camps. She is recipient of Rakta Data Shiromani Award, and she has got many accolades to her credit. So I welcome you, Kavita De. Dr. Ranjana Jha, she is also consultant gynecologist, Katihar Seva Sadan, formerly associate professor, MGM Medical College, Kishanganj, founder secretary, Katihar OBGY Society, and presently she is the vice president, Katihar OBGY Gynae Society. She is the recipient of Corona Warrior Award by IMA Bihar Chapter, IMA National Presidential Award, and special work interest in social work. Welcome, Dr. Ranjana Jhadi. Dr. Sadhna Sinha, she is secretary of Muzaffarpur OBGY Society, secretary of ISOPAB Muzaffarpur, past treasurer MOX, joint treasurer AOGS BJ, and consultant Apollo Maternity Zila Parishad Muzaffarpur. I welcome you, Dr. Sadhna Sinha, ma'am. Now, Dr. P. Vasantamani, she is consultant in Parvati Amal Hospital. She is the recipient of so many awards like Best Performance Award in 2018 from Department of Health and Family Welfare Award for Biomedical Center for the year 2018. She has lots of publication on maternal and fetal outcome in journals and many others. Post she has held Dean Government Villupuram and Kilpuk Medical College, and she has conducted many workshops and a very active member. I welcome you. Dr. Preeti Agarwal, she is a professor and senior consultant, Department of OBGY. She has undergraduate and postgraduate teacher since 2000. Welcome, madam. Dr. Alka, she is the assistant professor of Sri Ramchandra Medical College and Research Center. She is UG and PG. She has done her UG from Maharashtra and PG from Chennai, 7 years working experience. She has special interest in high-risk obstetrics, gynae endoscopy. She has got many research publications in national and international journals. Welcome you, Dr. Alka. So now over to the moderators for the panel.
Is my screen visible, ma'am?
Yes, ma'am. It's visible.
Make it full screen. You can make it full screen.
Visible now?
Yes.
Good evening. Very good evening to everybody who has joined this interesting webinar, and our session is very, very practical. I suppose so even the panelists, even the delegates who are joining them will have a connect to whatever situations we are going to put across in this panel. And I'm very happy to have a gamut of panelists from a very senior person to a very young persons like Alka Nadar. Next slide. I'm also thankful to Dr. Jayarani Kamara, the President of C, and to Suman Sinha for President Ranchi OBGYN Society for being the conveners of this CME. And I'm sure Dr. Indra Palo, an expert added in this panel, will add colors to this colorful CME. So we know current use of contraceptives in India is not as we expect. Only if we had done our job rightly, we wouldn't have overtaken China and become the first most populated country in the world. And high percentage of non-contraceptive users tells you that there is a gap in service delivery, and this CME will address how to reduce that gap. So there are too many challenging situations, like too young, someday they come for contraceptive advice, too old, near menopause, too many, too soon. So the challenges is to maximize contraceptive efficacy. At the same time, you know, we all know like none of them are without any side effects. So we'll have to make sure that they are with the minimum side health risks, and they have to be tolerated by the users. And we also have to make sure that the health benefits out of a particular contraception is put across to our clients. And at the same time, just because a newer product is introduced, don't switch over to a costlier one vendor. Less costlier one can give the equally good important results. So because at the center of all this, it's because the accessibility and because the cost factor that the family planning services have not gone to an extent what we are expecting to do in our country. The concept of triangle, if you see, so we'll have to assess what context she has come in. Does she want to postpone her first pregnancy, or does she want a gap between her first and second pregnancy, or she does not want to use a permanent method but wants to somehow pull on till she approaches menopause, or she's living in a relationship and wants to avoid pregnancy at any cost, or she has had a contraception, contact without any protective factors and she wants an emergency contraception. So you have to take the context and the woman's profile. Not everything will suit everyone. So that's why you'll have to be very thorough with the medical eligibility criteria, and we'll have to be thorough with our method profile also. I'm sure the panelists here will be able to highlight all the profiles of all the methods that you're going to aggregate to our varied group of population are going to come to us for contraceptive advice. So counseling does improve continuation. Counseling. That's the only thing. So you should not go back on your words. If you say like the copy is good for you, stay with that. Okay, it's not, and you keep on changing along the patient's complaints, then the patient and the attender will lose faith in the system. So now we to set the ball rolling. I am sure like we'll allot 4 minutes for each of the scenes so that we are able to complete all the 10 scenarios in the given time. So the first scene goes to Dr. Alka Nadar and Dr. Chitra. It's about pre-pregnancy contraceptive counseling. Sometimes it started happening of late. For the last 2 years, I am seeing a lot of people coming for pre-pregnancy contraceptive counseling. And this is a typical scenario. Mrs. Lakshmi Srinivasan, married for 1 month, regular cycles, no medical comorbidities, wants to postpone first pregnancy by 1 year as she has no official commitments. Madam, you can take up, madam, either Dr. Alka or Dr. Chitra.
Yeah, at the outset, I would like to, am I audible?
Yes, very much, ma'am.
Yeah. At the outset, I would like to emphasize on the need for counseling, as you rightly said. Earlier, the contraception, the main indication used to be population control. But now with the social media promoting sexual awareness in very young youth, even at a very impressionable age, they are exposed to sexual awareness and all. So premarital sex and premarital pregnancy has become a very common thing these days. So the first and foremost thing is, I would like to emphasize that marriage has nothing to do with pre-pregnancy counseling. That is the sorry state of affairs we are in right now. As for this particular scene, that first scene one, newly married woman, ideal would be contraceptive condoms. Wouldn't you agree with that?
Yes, ma'am. Yes, ma'am.
Yeah, the contraceptive condoms, it has got many advantages. This is most inexpensive and cost effective. And of course, it offers good protection against sexually transmitted diseases also. Easy accessibility and portability, minimal side effects, and it's very hygienic. But the important thing to notice, it needs male participation. So if the male is also tuned to protecting the woman from pregnancy, this is of course the ideal. And main thing, complaints from the men's side will be they complain of reduced sensitivity or erection, and they may feel embarrassed to go and obtain the condoms from the drug stores, or it is very inconvenient for every act they have to use the condom. And of course, latex allergy, and then slippage or breakage of condoms. That means spilling of semen unknowingly into the vagina. And of course, incorrect usage. In this regard, there was a small joke I would like to share. One of our social workers, where she was just educating the very ignorant, villagers. So she just to show how to use the condom, she used her fingers to show the condom. And within a couple of months, the woman comes pregnant. And when we asked them how did you use the condom, this is how they were telling that her husband was using it in the finger, and then, so this is just by the way. So these are things that men need to be, both the women and men to be educated. And for the latex allergy condoms, I think we can use the newer ones, the polyurethane condoms are used now. It has got more advantage in that it is thinner, and it can be used with any lubricant. It is also more heat resistant. And the worst thing is the 9% of pregnancy can occur failure of polyurethane condoms. The pregnancy rate is much more than with the latex condoms. Disadvantages, because of it is thin material, it tends to break during use. And of course, lesser protection against STI, and it is costlier. So,
Alka, do you have to offer anything other than what madam has already told?
Ma'am, it depends now again. First, I would appreciate if she takes up this condom, because condom is the only contraceptive which will protect her from sexually shared infection. So that is a must. But we have to tell her that it is not going to effectively protect you against pregnancy. So she should use another method as well. So in that case, depending, now she's saying that 1 year I do not want, then again I would counsel her for using some long-acting reversible contraception where copper IUCD is still a good option for her. And various other options, like injection DMPA also, which can be offered. But copper IUCD is the best one that I can give her for a long-acting reversible. But condom is a must, like whatever it is.
Yes, yes. Even though it might have a high failure rate, but correct and consistent use might reduce this failure rate to some extent. As you said, more than contraception, it protects against sexually transmitted infections. Thank you for the input. And Dr. Leena.
Yes, ma'am.
Leena Garu, would you like to take up the second case, madam?
Okay, ma'am. Okay. Good evening, all of you. The second case we are going to discuss about the antenatal PPICD counseling. And this is a case, Mrs. Sneha. She is 27 years, a teacher, married for 2 years. She is a primary gravid, conceived spontaneously, no obstetric or medical comorbidities, regular antenatal visit and 38 weeks. And she came to you in the antenatal ward. So what the counsel you will do about the PPICD? Anyone will take the question, Dr. Ma'am?
Thank you.
Yeah.
Thank you. First of all, I would like to thank Jayarani madam and all the moderators who are here, even seniors, for giving me a chance to participate in this useful webinar. Just Chitra madam has said a joke. I'm also sharing a small, just I will take 30 seconds. Yeah, we were PG students in a government college and PMCs. So there women used to come from very rural areas. So at that time we had to give 5 condoms to each couple. Okay, this, your husband has to use. So what happened after 3 days, the couple came कि मैडम मेरा हस्बैंड तो खा गया किसी तरह से, तो 2 चबा गया, अब नहीं खा पा रहा. He ate 2 condoms. They came कि madam now he cannot eat anymore. Then we thought कि how we have done counseling. So counseling is so important. Just Chitra madam has shared. So we have seen in our college PMC Patna. So just I shared this one. Yes, he shared. So this is the really importance of counseling, that we have to share everything, by whom it has to be used and when has to be used and how it has to be used. So this is the importance of counseling. So okay, so I'm here to speak on PPICD. So yes, madam. When patient comes for antenatal checkup, at that time only we have to consult for contraception, because this is the best time when one can consider and one can think for planning the family. So as she is, I think she is working, right? And she had no medical comorbidities. So we will discuss that after, even if she delivers normally or cesarean, whatever the method, we can use IUCD immediately, just after normal delivery or after cesarean section. Only thing is, if the patient has any history of preterm premature rupture of membranes, if there is any history of choriomyelitis, any history of PID, or even after delivery, if there is severe PPS which could not be diagnosed, and there is many more even tears and which was repaired, but still she is bleeding, then we can't apply. But after delivery of the baby in placenta, just wait for 10 minutes, everything is fine, then we can apply IUCD. But before that, we have to consult the patient. And sometimes if there is any altered anatomy because of fibroid or because of any anomalies, then there may be difficulty in applying IUCD, but mostly it goes easily. Just you have to see if she had delivered vaginally, we have to use ovum forceps, and we can take the IUCD up to the fundus of the uterus, just straighten the uterus, and it fixes mostly, and there is no need of cutting the thread. So it can be easily applied, but we have to consult the patient during pregnancy only. And it can we have to consider also that it can be used simultaneously. You have not to worry for anything. You have not to come for again for IUCD. Just you have to come once for whether the IUCD is fixed or not. Just and we have to say her that if there is any history of expulsion or any abnormality, then she can come. Otherwise, mostly it goes well, and it is very good contraception for long run.
But the patient should be definitely informed, madam, earlier.
Yeah, exactly. Yeah, that had to be done, madam, during pregnancy and after delivery also, whether she is going for cesarean or normal delivery. Every time we have to consult the patient, and we have to take suggestion from her, in fact, family members also, because many times in government hospitals, what happens, just we saw a case,
copper T was put inside and nobody knows. And she came after 3 years, ki, madam, humko bacha nahi ho raha. And when we did ultrasonography, found copper T, and she had no idea. So we have to counsel and we have to suggest that we have to tell her that copper T has been applied. So that has to be mentioned, even in written should be given.
Yes, very rightly, madam, you have said. But one thing I like to, when you are giving the PPICD, then you must document it and give it to the patient also.
Yes.
So that summary should have one sentence at least that PPIOCD is introduced. Because
yes, in the ticket it should be written, highlighted, and that PPICD has given. Most of the patients, they will come to you when after postnatal checkup after 6 weeks. Then that time also we can just examine the patient. But most of the time this PPIOCD is coiling out inside there. So don't need to worry about the seeing the threads at that time. The post digits.
That we have to consult. Don't worry for the threads. Even if it is coiled up inside, no worry. If there is any doubt, we can go for ultrasonography. Otherwise, there is no risk. And we have to also tell her that there can be some bleeding pattern alteration, but she has not to bother for that, and it will get controlled as usual. When it stays for some time, the bleeding pattern will be normal also. If there is no history of any infection or any PID or any sort of abnormality.
Thank you, ma'am.
Yes.
Now,
the next
short video, short clippings of how PPIOCD should be introduced, and this is available in the NHM guidelines. Okay, either you can use a sponge loading forceps or a special Kelly forceps can be used, and how counseling is done, how documentation is done, and how a simple finger holding technique itself we can introduce this property nicely into the fundus. Okay, now coming to scene 3, which will be shared by Dr. Kavita Barnwal and Dr. Preet Agarwal. And Dr. Preet, this is your patient, a bank employee, so which means she must be educated. She had a spontaneous conception, she had a normal delivery with episiotomy at term, she had a healthy baby reports at 6 weeks. Not willing for PPIOCD at delivery. Like the second scene, people tried counseling her, Dr. Kavita counseled her, but she was not willing. So wants to know if only by breastfeeding alone will she be able to space a pregnancy for next 2 years, and what will be your counseling points to this particular lady, Dr. Pramila Rajshekhar. Dr. Preet.
Thank you, ma'am. It's nice to be in the group of my old college. I'm from Orissa, and I'm happy to see Dr. Indra Pala and Dr. Sashmita, who all are my teachers and my seniors. It is nice. Thanks, Dr. Jairani and Dr. Dhanalakshmi, for giving me this opportunity. Now, regarding this lady, she says that she wants contraception for 2 years. 2 years postpartum lactation is not good. According to the Bellagio consensus, excluding breastfeeding has got complete amenorrhea and offers it only for 2% failure rate is there if it is correctly the lady feeds 8 to 10 times per day, at least once at night for a long time, and then only the protection is less than 2% failure rate is there only for 6 months. But if she gets her periods before that, or if she gets her stops feeding or is intermittently feeding, then it is not a good method. But there is a myth. So many people think that if they are exclusively breastfeeding, then they will not get pregnant. But there are chances of ovulation, even if they are continuously breastfeeding them. And so many times the ovulation occurs even prior to menstruation. So we have to counsel them that yes, it can prevent for 6 months, can be started. It is under the control of the female. No procedures is required. No hormonal side effect is required. Good for breastfeeding, but it has got its own side effects, like for the working females who have to wean off the babies earlier, and also for those people who are HIV positive, and the other cases are there where they need to use other methods of contraception. So hence, for this lady, I'm going to tell her, yes, you can try exclusive feeding as a contraception, but not for more than 6 months. More than 6 months, yes, we have to try other methods also.
Yeah, and we have to advocate about the importance of breastfeeding, because not
Yes,
only
ma'am.
baby gets benefited with this breastfeeding, if the baby gets immunized from against major diseases like GIT infection, respiratory tract infection, even it the baby gets protected from asthma in future. So we have to tell her, and we have to also consult that breastfeeding not only corrects her body figure, but it also protects from the breast cancer, from the ovarian cancer. That we have to consult her, and it
Yes,
there
yes.
is no interference with the sexual relationships. So everything we have to explain her the importance of
Can you tell
breastfeeding.
us what are the physiological changes that happen during breastfeeding by which
During
ovulation is altered or
yeah,
changed?
yes, ma'am. Yeah, there is increase in prolactin levels, okay, for breastfeeding, and this inhibits the FSH and LH, and it causes a reduce in GnRH from the hypothalamus, and therefore there is the lack of follicular maturation and anovulation occurs. So that is how the breastfeeding helps in
Yeah,
anovulatory
and it
cycle.
also
And
increased prolactin level also extend the hypothalamus, and it causes down regulation of GnRH also. So
yes,
there
yes.
is the estrogen is less, and thereby irregular cycles, erratic cycles, luteal phase is short, and thereby there is no follicular maturation, and even it causes oxytocin release. It also prevents pregnancy. So these are the normally methods of breastfeeding.
So as Preet rightly pointed out, 6% ovulating in before first postpartum menses. So even if she's fully breastfeeding, ovulation can occur as early as 21 days after childbirth. So it's not a foolproof method. That's why you have to give the 2% per year rate with this kind of a method. But nevertheless, but when a patient is determined to do exclusive breastfeeding 6 months, advise her and counselor and be with her, supportive to her, and tell her like after 6 months or anytime she gets a periods or she's not able to do the full exclusive breastfeeding, she has to adopt alternate methods of contraception. And return to fertility is uncertain and difficult and inconvenient for working mothers, as Preet rightly pointed out. And of course, if the woman is very sensitive to HIV or STIs, she has to have additional protection through condoms. And of course, this is a good thing only to prolonged lactation leads to superannuation uterus is a good thing only. And this amenorrhea, oligomenorrhea, which can occur because of high prolactin, sometimes they take about 2 years to resume their periods after, even after stopping periods. That all that we can counsel them. We can be with them. We can tell them it's like a little physiological overdose. So again, just because you're using some other methods of contraception, need not have to stop breastfeeding. Suppose she's using condoms or she's using progesterone pills or injectable contraceptives. Just because she's not able to fully follow the fully exclusive breastfeeding need not be stopped. And be aware the risk of pregnancy increases with the onset of first postpartum menstrual cycle. The introduction of supplementary milk, and after about 6 months of delivery. It is only for 6 months, provided the Bellagio criteria are met. Now coming to the fourth scene, which will be shared by Dr. Preet and Dr. Ranjana Jha. Mrs. Kalexali Shekhar. Can I leave it to my other co-moderator? Madam?
It is audible? Okay.
Yes, ma'am.
Okay.
Madam Leena Baru? Yes, ma'am.
Mrs. Kalsve Sekhar is 29 years lady, an IT employee, married since 1.5 years. She's para one living one, assisted vaginal delivery at term. There was moderate PPS and managed medically since fine. The offered cafeteria approach at the first postnatal visits. So she says choose to IUCD. So what is your take, ma'am, on IUCD?
Ma'am, IUCD has got a very good Pearl index. Like the failure rate is very, very less. But what happens is it is always underutilized in our country because we have not got trained personnel who can put the IUCD correctly in the position. And even one lady who has got an increased bleeding tells the whole people, everybody that it is not a good method. But around the 97-98% of the ladies who are using this copper T and are doing well never let it out. That is what always I feel, that one person who has got negative bleeding or something, they tell everybody around that it is not good. So there are a lot of misconceptions in the healthcare providing and the public. And of course, the side effects are there in the first 3 months. They will have lot of heavy bleeding, prolonged bleeding, but we always counsel the patients and give them tranexamic acids and other things for the first few years. for the first few cycles, use aseptic methods to put in the copper T so that they do not get the infection. Inform them that the thread is outside, and whenever they get the white discharge and all, they can use the local suppositories and all they can use. And always there is a fear of expulsion, perforation, missing thread. This is always there. But a person who is clinically experienced and has put the copper T in the correct position, I don't think we see any of these problems.
Yeah.
This thing, may I speak something?
Yes.
Moderator,
Please,
madam?
Yes.
Yes, ma'am.
Yes. I fully agree that counseling is the best part, should be done before insertion of any copper T. But this counseling to whom? It is not the patient. The first person to be counseled is the
Mother-in-law.
mother and mother-in-law.
No,
The
yes, ma'am.
second person to be counseled is the husband. Third person to be counseled is the neighbors, the peers. And fourth person to be aware, that is the media. And most of the time, whatever counseling you are doing to the patient, they at the time they may tell you, yes, you can introduce, but I have seen that many patients are coming after 1 and after 1, please remove the copper T. My husband does not want, my mother-in-law does not want, I'm not staying. So the thing is, the counseling to whom? That should be now you have to revisit it, and should be introspected not only to the patient, the Asa Karmi, those who are, because the patients will listen to them better than us. So the counseling should be, and awareness should be reached to the each and every person in the village level, so that the acceptance will be more. We are introducing PPICD, no doubt, but the removal rate is more than what we are expecting. So it is not the counseling is to the patient. Counseling to the patient, husband, mother, and mother-in-law is the two most important influential person in a woman's life. That they should be counseled properly so that the acceptance will be better.
Madam, just
Yes, Indirappa. Yes.
One word, madam. I think if we put copper T under ultrasound guidance wherever possible, that rules out a lot of problems. And the patient also gets reassured. In my clinical practice, that is what I do. I just take a picture before copper T insertion, half a picture, and after copper T insertion, I take the other half and give it to them along with the the date and other details. I give this picture also, so they will know that. Actually, it works a lot, particularly in the
Good idea, ma'am.
literate crowd. They really appreciate that, and they come with lesser complaints later on. That is my personal experience, ma'am.
I have experienced that PPISUD is mostly applied in government hospitals, and proper counseling is not done. When they come for any other problems, an ultrasound is done, ultrasound shows PPISUD, so they come for removal of the proper counseling is the main problem for removal of them, because they do not know कि copper T लगा दिया बिना बताए हमको लगा दिया. Every month I remove one patient from government hospital where PPISUD is applied.
And copper T should be ideally inserted post-menstrually and removed pre-menstrually. Removal pre-menstrually is mostly nobody follows it properly, ma'am, because the patient would have just crossed, only at the pre-menstrual period, you can be very sure that she will not conceive she wouldn't have conceived in that cycle. The protection would have been throughout the ovulation period. So if they remove it at post-menstrual phase, the patient is likely to go in for pregnancy in that same cycle, which may be unplanned. So, and it can also result in poor endometrial ripening and endometrial reaction. So the decidual reaction may not be very good, and it may end in abortion later on. So I always counsel them to get it removed pre-menstrually. Insertion only should be post-menstrual. Many people have this misconception that it should be removed after menstruation. Because it was put in after menstruation, it should be removed after menstruation. That is wrong. We have to enlighten the patients on that also.
I think it can be applied in any day of the menstruation also, except pregnancy should be ruled out.
When you are removing it, canal remains open. So it's easier to apply just during menstruation.
Menstruation.
Cervical canal is open, so it will be easier. Patient will have less pain, less cramps, I think.
Madam, whatever you do, when you're removing, tell her that she's going to get pregnant the very next cycle. That should be conveyed, madam.
Yeah.
Because many a times they assume that they will not get conceived for the next 3 months. So that should be conveyed to her. When I remove a property, you will be pregnant next month. We put that here into our mind before removing the copperty. And advantages, Dr. P.
It is
Ma'am,
it is long-term contraception, highly effective, and there is no drug interactions with this drug. And most important is that the return of fertility is soon, and there is no relation with the intercourse also, and patient satisfaction is also more in this.
And can be given in a patient women with comorbid condition like diabetes, hypertension also. There is no interaction with any drug or anything, so we can be given.
In one line, fill it, shut it, and forget it.
Yes.
Thank you so much, ma'am, for your feedback.
Can IUCD be used in
Can be used in adolescent nulliparous, but I think it should not be used in adolescent. It can be used, but it's better not to use in adolescent.
It can be used, but we don't give
it. Better not to use.
Yes,
I think.
Madam, adolescents who are sexually active. Adolescents who are sexually active, we can give them that option, madam.
Yeah, WHO says,
but in our part, we don't give it.
Proper counseling should be done. That is, it is not good. And if sometimes, then condom. No, I think no IUCD in adolescent, in my opinion.
But no, madam, we should be aware that IUCD, if you are prescribing to an adolescent, it is not wrong. The adolescent who is sexually active, who had been using repeated emergency contraception, who had been coming for repeated medical abortions, they are the people. See, I'm not saying adolescent who had a first time sexual offense or she had a some rape or something like that. I'm not talking about those kind of adolescents. Adolescents who are fully aware of their involvement in sexual activity can be counseled for an IUCD if they have had more than one time offense done. So instead of going for repeated medical abortions or repeated emergency contraception, this one time would be a better option. Of course, this is not going to protect against them, against sexually transmitted infections. That also should be advocated to them. Women with previous pelvic infection, yes, if it had been completely resolved, they can have. And women with HIV, yes, if they are well under control, yes, the CD4 counter is above 400, they can use IUCD. I'm missing IUCD threads. Either Dr. Ranjana or Dr. Preet can take up this.
In a majority of the case, missing IUCD is that thread is coiled up or thread is torn off. Major two cause of missing IUCD. We first we do ultrasound to know whether whole IUCD is missed or only thread is missed. After after doing ultrasound, either we remove. If thread is visible, then nothing to do. If thread is not visible, then which I do is under IV anesthesia, we try to remove the cavity either by hook, IUCD hook, or even sometimes with curate it is also removed. If not, then hysteroscopy guided removal of IUCD is done.
Ma'am, just going to the.
I think
just
if
recently I went.
the thread is coiled up, then why we will remove IUCD if the patient has not any other complaint and she is satisfied with IUCD? We have to consult that.
If she wants to remove, that.
Okay, then then this is this different thing. But if missing thread, then we have to see whether property is placed in a right position. Then we have not to.
Once thread is missed, she thinks that अभी thread miss हुआ, अभी ये perforate करेगा, आगे जाएगा. इसीलिए
that we have to counsel. I think
निकाल दीजिए मेरा, अब हमको नहीं चाहिए.
If the patient doesn't want, then we can go for removal of the IUCD. But I think we have to consult because
one more thing I went through.
One person at a time, please. Yes, please.
Ma'am, one more thing I went through when I was reading to the missing copperty is if the thread is if the copperty is in position, you just take a cyto brush and put it and just take it out and the thread comes out.
Yes.
So it is one other method. If it is a coiled thread, it is very easy to do it off. One practical tip I thought we'll just share it.
Only thing is the pain control apprehension. The patient becomes very, very apprehensive and she loses faith in the system. Now, whatever neighbors told her, no, all will come to her head. Okay, I told you no. Let that
no, but what we can do. Yeah, so that is one way to relieve. Yeah.
You can use any method.
In my one case, copperty was into the myometrium. It was, I don't know by what, it went into the myometrium. Then I have to do laparoscopy. Then I removed because it was not possible to remove through hysteroscope also. Then I did laparoscopy and one hand was visible. from the peritoneal on the peritoneal cavity, then I just removed it. So it happens sometimes, not commonly.
The next scene will be shared by Dr. Ranjana and Dr. Sadhana. We'll go a little faster. We're already running short of time. And patient wants an alternative effective contraception for another 3 years because now that property was coiled up, somebody, I mean, she wanted it badly removed, and so she wants to have a effective contraception for next 3 years. Stop breastfeeding by now. Planning to join back office physically. So, Dr. Ranjana or Dr. Sadhana.
Yes, ma'am. I will prescribe her. I will give her a basket of choice, either OC pills or long-acting progesterone, DMPA. If she wants fixed menstruation, then I will prescribe her OC pills.
Yeah, we have only a monophasic pill. So
we are usually prescribing monophasic. Although triphasic is available, but we are mostly prescribing monophasic pills. And in monophasic, in the first month we give high dose such as overall L, but later on from next month we prescribe low dose OC pills. Because in the first month,
generation,
if we prescribe low dose OC pills, then chance of failure is more. So first 7 days.
Dr. Sadhana there. Has Dr. Sadhana joined us? Dr. Sadhana?
And Sadhana could not join. She could not join. She has gone to receive
okay,
daughter, so she's not here.
Okay.
This was her message.
Okay. Then Dr. Ranjana can continue with the non-contraceptive benefits.
I prescribe low dose OC pills only for first month. High dose OC pills such as the 30 microgram with estradiol. Later on, I give low dose OC pills because in first month, if low dose is given, then chance of failure is given. And if we prescribe low dose for first 7 days, I have to give extra precaution to them. And there are so many benefits of OC pills beside contraception, such as if she is suffering from anemia, endometriosis, dyspareunia, heavy bleeding, mostly heavy bleeding, that will control. And mostly if as she is, if she wants that her cycle should be, her main complaint is cycle regulation. So by giving OC pills, her cycle will be regulated. And it also prevents some cancers, also some benign breast disease. It is also helpful in ovulatory.
But there are certain side effects with estrogen component, like migraine, headache, aura. So that we have to see if the patient is
that's why,
case of migraine.
That's why I am giving low dose OC pills of 20 micrograms.
Pap smear should be taken because there are certain changes in the cervical smear. So we have to advise our pap smear also.
Yes, every 5 years pap test should be done. But mostly patients do not want to take due to nausea and vomiting. Majority of the patient complain nausea and vomiting. Migraine and headache is very less common. Nausea and vomiting is main complaint by the patient. And some patient also complain weight gain. I don't know whether weight gain occurs or not, but
breast pain. Many women complain of breast pain also.
Yes.
breast में pain हो रहा. This is
और
also
बहुत सारे many patients do not want to take their bleeding बहुत कम हो गया है. वो भी नहीं लेना चाहती. पहले ठीक था. उनको लगता है कि नहीं सब जमा हो रहा है, यूट्रस में जमा हो रहा है सब, उसलिए भी नहीं लेना चाहती बहुत सारी.
And we have to see, take the history also, whether she is having any medical disorders like hypertension, diabetes, that we have to rule out.
Prescribing
this is very important.
Lipid profile should be done, blood sugar test should be done, BP should be measured, then only OC pills should be given.
And history in the family also, whether she has any history of thromboembolism or any history of like thrombophilia and all these conditions, that we have to see. So taking the history and by doing the examination, then only we can
reduce a risk of ovarian CA and
colorectal, endometrial.
And
yes,
CA, there seems to be a small increase in risk of breast cancer, but reduces after 10 years of discontinuation. But benign breast disease, no further increase in risk. And we have to know the category to which she belongs before prescribing OC pills. We'll have to be very, very thorough with this. And you can start it on the first day, which is very, very useful. But on first Sunday, we don't follow that first Sunday. I started within first 5 days, preferably first day after she gains about 2 or 3 pads. And quick start. Have any of you have started quick start? I have not done it, but it is given in the literature. That is, when she visits you, you start on the same day.
And mostly we give from first or second day.
Yes,
I
first
give
day,
low
first day.
dose pills from first day. Yeah,
First day,
like
okay.
with
All of us.
drospirenol, we give 120 microgram
I give any pills from first day.
Okay, so can somebody highlight on drospirenol?
Yeah,
Yes, it is a fourth generation
progesterone.
of progesterone. It's a fourth generation. It has anti-androgenic effect. It is very good in prevention of acne. In PCOD patients, it is very good. And main is it is anti-androgenic.
Yeah, actually, it has no androgenic effect, no glucocorticoid effect. So there are less chances of acne, hirsutism, chances of venous thromboembolism is risk is low.
But in comparison to levonorgestrel, it has more risk of ET. In comparison to levonorgestrel, it has slightly more risk of ET.
For want of time, I skip this 4 lines. How the newer formulations have come up, where you are trying to reduce the hormone-free interval between one pill and the next pill. That is, you are trying to bring it down to 7 days to 4 days to no hormone-free interval is what we are heading towards the newer pill, extended regime and all that. So because this time is running out, already we have crossed 8 o'clock. So
our
we'll
patients wants menstruation every month, so they will
Yes,
not
madam. In our part, nobody wants extended
every month.
regime.
She wants
They
menstruation.
want menstruation every month.
Yes, there are so many advantages, but she will not take.
Yes.
She will not take, but patients with endometriosis will prefer.
Yes. Yeah. Even with the Dimpa injection, they say what they have not menstruation regularly, so we'll not take next time. So this is the usual complaint in our part.
And now Dr. Sadhana Sinha is not there. Dr. Vastamani will take up this case. Dr. Leena.
Yes, ma'am. Now this question for Dr. P. Vasantamani, ma'am. In this patient, she has a missed pill. How will you take the history of in which week they has missed the pills? So how will proceed?
We have to ask her whether how many days she has missed and which part of the week she has missed. So if she missed pills for 1 or 2 days, if she missed for one pill means within 24 to 48 hours, she has to take the missed pill as soon as possible. And she should resume the original schedule as usual. Here, the backup contraception is not necessary. But if she missed more than 3 or more pills at any time, whether in the first week or in the second week or third week, then if she had any unprotected sexual intercourse, she has to take an emergency contraception within 72 hours of contact. And for the rest of the cycle, she can continue the same thing with taking one pill. And in between, she should have an backup contraception for another 7 days.
She has to start a new pack. She has to start a new pack with backup for 7 days. So whatever she had been taking, that should be, because more than 3 pills, that pack is useless. She has to start a new pack and then have a backup for about 7 days.
For another 7 days.
Okay. So if it is only the missed pill which are missed in two missed pills, then we have issues. Depends on
if she misses a pill in the first week means, if she had an unprotected sexual intercourse, most recent pill she has to take immediately. Then the original pack she can continue. If in the first 7 days means, she has to avoid contact or backup contraception is needed. But if she has no emergency contraception is needed in the first week. If she misses the pill in the second week, 2 pills, then emergency contraception need not be provided for first 7 days. But she has to take 2 tablets immediately. Then she has to continue the pack and finish the pack. But backup contraception is needed for another 7 days. But week 3, then it may need not take the pack. She can take a new pack and restart the cycle.
So in week 1, you need an emergency contraception. UPSA has occurred. Okay,
yes.
And then the most recent pill should be taken immediately, and backup contraception is advised for next 7 days. If it is week 2, provided the first week she had taken all the 7 tablets correctly,
regularly,
then take
emergency
2 tablets
contraception
and
is
continue. Need not needed. Then take 2 tablets and continue and finish the pack. Whereas if it is week 3, you will have to see, normally the 7 days placebo time is given, placebo period. That placebo period is not given. Instead, after finishing the 21 active pills, they have to start the next 21 active pills.
Yes.
Okay, that 7 days pill-free intervals is not given when she misses the pill.
You have to take the next pack immediately after.
Immediately. After the active pills is over, after the 21 pills is over, she has to take the next set of active pills. That is white tablets. If it is a Mala N or Mala D, she has to take the white tablets.
She has to omit the non-hormonal tablets.
Yeah, like iron supplements. So if it is POP, that is progesterone only pills. See, this woman had taken only combined oral contraceptive pills. Okay, but suppose she had been prescribed progesterone only pills.
So the progesterone only pills has the disadvantages. If they miss the pill more than 3 hours, then the protection differs. And especially for dysonogestral, if it is more than 12 hours, the missed pill should be taken immediately as they remember that they have missed the pills. But if one pill is missed, that pill can be taken immediately. Then the regular pill should be taken so that she can take 2 pills in a single day. Additional contraceptive precautions should be given, either a condom or an avoidance of sex. And she should be advised abstinence for another 48 hours after restarting the progesterone only pills. Sometimes emergency contraception is needed if she had an unprotected sexual intercourse within that 48 hours of missed pills.
Thank you. Now we are coming to the session, case scenario 7, which will be shared by Dr. Alka and Dr. Vasamani ma'am. And now, as madam already pointed out, she'll choose the other methods like DMPA or Mirena. And can you talk a little bit about any of this longer?
Yes, the other hormonal contraceptive devices may be intrauterine contraceptive devices, implants, dermal patches, vaginal rings, and spermicidal jellies. All these things can be practiced, especially those who have contraindications to use combined oral contraceptive pills or progestin pills. These are very suitable for those patients who have comorbid conditions like hypertension, diabetes, hyperlipidemia, all these things. So we can practice with the implants or with the intrauterine copper contraceptive devices or hormone releasing levonorgestrel intrauterine devices. Sometimes the compatibility is good with implants. And many of the government hospitals will be using Norplant 4-2 and implants. So sometimes 70 milligram of levonorgestrel, 2 silastic rods can be implanted subdermally. So it can release 50 microgram of levonorgestrel every day. So it has a failure rate is very, very less. Acceptance also very high.
Yeah, recently central government has conducted a training program for most of the government doctors, and I hope this implant takes up in a large way so that it's quite acceptable to most of our patients. Alka, do you have anything to offer in this where we are discussing other options for your lady who had a property, then she had a missing threads, and then she had a OC pill.
Injectables also.
Yes, ma'am.
In injectables also we have a very good place. And especially in government institutions, we are using the progesterone and Netin very well, either once in 3 months or 150 milligram or 300 milligram once in 6 months, or Netin 200 milligram for every 2 months. This is acceptability. Only thing is breakthrough bleeding, sometimes missed ovulation. So pregnancy may rarely occurs. So this is also very useful. And we very much practice it in many of the government institutions, and mainly after 6 months in the postpartum contraceptions.
Yes, ma'am. And one more point, when the patient is taking this Depo-Provera, her return to fertility is also little delayed. So that also has to be very much kept in mind when we are offering this. Otherwise, it's a very good contraception. Little discomfort with the breakthrough bleeding, as madam suggested.
And sometimes there is amenorrhea also. So
yes,
this is
very,
also very
distressing amenorrhea.
even after
6 months,
3
1
months.
year, 2 years. Yes.
Madam, but if a patient has adenomyosis or associated fibroid and other things, she'll be more than happy to take a Mirena for contraception, ma'am. We can offer her double edge.
Yeah, if she has any bleeding problems and adenomyosis, Mirena, levonorgestrel IUCDs will be better option. and it's more life. So even 5 years, 10 years, you can use continuously without replacement.
She'll be happy with you. Yes, ma'am.
Way of addressing this emergency contraception. Let us hear from our experts, Dr. Alka, Dr. Chitra, and Dr. Kavita, about our patient, Dr. Leena.
Yes, ma'am. This is a case of 24 years old.
Leena?
Yes, ma'am. It is audible. Am I audible?
Yeah.
Yeah. This is 24 years old walk into the clinic with her living-in partner with request for emergency contraception as there was a condom breakage the previous night. So she will come to you. Then what counseling you will do, or what the emergency contraception you will advise?
Yeah, I think since only it's less than 12 hours, so we will give her estrogen progesterone pills, that is 100 microgram ethinyl estradiol with 0.50 microgram progesterone, and that will be sufficient. We will ask her to take 2 tablets start, followed by 2 tablets after 12 hours. It's very effective if taken within 72 hours. So I think this will be sufficient. That is USP method. There are other methods also, like intrauterine contraceptive device like copper T, that can be given even after 5 days. Ulipristal, that is selective progesterone receptor modulator. It also has been used as emergency contraception, but it only delays ovulation for 5 days. So there is risk of pregnancy if the patient comes with late ovulation. So I think in this case, when she had just missed think and condom rupture last night, so this will be OC pills will be sufficient as emergency contraception.
Also, ma'am, we have to see whether she has, what is the date of her ovulation, ma'am? Because if she has not reached her ovulation date, then IUCD is always the best option. But if she doesn't want an IUCD, then UPA is the best option for her. So that is something which we have to keep in mind while taking the history from the patient, whether what is her ovulation time period, ma'am.
Yeah.
Yes.
Yes, very important.
Before prescribing any
And this is safe and unsafe period is also should be discussed with the patient, especially who are literate, and they are staying together. Then we can tell her about the safe and unsafe period also. If they don't want to use any other contraception, then we can tell them that this is unsafe period and this is safe period. That is also
taking is very important.
Yes, ma'am.
Yes. Then who can use emergency contraception?
Emergency contraception, basically, it depends on whether the patient is a regular ovulator or not. If she's an irregular ovulatory cycle, irregular periods patient, then the whole scenario changes.
Yes.
Copper IUCD will be ideal for such patients. With the ulipristal emergency pill and LNG-EC, both we need to know whether the patient is ovulating and what is the phase of menstrual cycle she is in at the time of unprotected sexual intercourse.
Yes.
Before prescribing any emergency contraceptive pill, the first question was to what is her date. If it is in the first week of her cycle, then emergency contraceptive pills works in 2 ways.
Need not be given.
One is preventing the ovulation,
Yeah.
second is preventing the implantation. If she is in the first week of cycle, the what are the combined OC pill works and the levonorgestrel pill works. But once she is in second week of her cycle, then already ovulation has occurred. So you are not sure how much the prevention of implantation will work. So it is better to give an implant actually, but it mostly in any practical purpose, patient never wants to give a cup of tea. So you have to be very skeptic and you have to counsel that how she is, whether it has worked or not, and she has to come immediately if she misses her period. So it is not 100% effective once it is in second week of cycle.
Second half of the menstrual cycle, right?
Already, if the implantation has already occurred or in due course, this how much of contraceptive pill you are giving, it may not work. Even if ulipristal EPA also may not work. So she should be counseled if she misses her period.
Yes, thank you all of you. I think Madam Dhanalakshmi Madam has stopped the sharing the slides.
I think it's 8:25. So actually it was supposed to finish by 8 p.m. So, okay. Thank you. I think Madam wants to continue or what?
Actually, slides are not with me. If anyone can share the slides, then I will.
Network issues, I think, with Dr. Dhanlakshmi.
Okay. Dana ma'am has come.
Yes.
Myself, yes, sorry.
Yes.
Is my screen visible? No.
No, ma'am.
I'll just share it. I'll just share it in a minute. Sorry for the thing.
Somebody has written about Sandchroman. Yeah, it can be given, especially in lactating mothers. It's very effective when it controls menstrual disorders also. Somebody has written that we give 60 milligram twice a week for 3 months, then 60 milligram weekly for next 3 to 6 months. Somebody has written about Sandchroman, and it has very good effective contraception also.
Connectivity is some problem, I believe.
Actually, there is one very important slide I wanted to share. There are only 4 methods of emergency contraception. One is combined OCPs. That is, immediately we have to give 2 tablets, and 12 hours later another 2 tablets can be repeated, combined OC pills. Second is that ECP with ulipristal emergency contraception with ulipristal acetate. So that is another. Third one is emergency contraceptive pill with LNG. And finally, copper IUCD. Only these are the 4 main modalities of emergency contraception. But there are some smart girls who just on their own, they go to the pharmacy and they ask for an EC pill and they swallow. So we don't know in that scenario what is whether they have taken EC pill with LNG or with UPA. So in such cases, it should be brought to the notice of the doctor, whatever prescription they have taken earlier. Because if they have to, when they have to repeat it after 12 hours, it should be, if they take ulipristal, they should not take the LNG pill after the second dose, as the second dose. So they have to maintain the same modality of pills. So that is the only thing. If they take it on their own, then we are at a loss to treat them properly, isn't it?
Okay. I think ma'am is
right.
Ma'am, you can read the slides, ma'am.
Dana ma'am, you can read the slides because you may be knowing it from your desktop. You can just
Dana
read
ma'am, I'm having your slides with me, ma'am. Shall I share, ma'am?
Yeah,
Please share it.
Shall I share the slides, ma'am?
Yes. Please go ahead, Chitrakala.
Okay, ma'am.
Open your slides.
I'm not able to get it.
Your slides are not visible, ma'am.
Yeah, my slides are not visible, not getting visible.
Yeah, I am sharing the slides, ma'am. Just tell me in which
final one.
Yeah, this is it. Okay.
Okay.
Should I take these questions or?
Sorry for that.
This is case number 9.
The previous slide
mother-
you can see. Yes.
Yes. So we have completed emergency contraception. Have you?
Yes, ma'am, you are completed. You can go to case number 9.
It is unwed mother. Next slide. Mother brings a 16-year-old daughter. It's not very uncommon these days. Are we sensitized in the adolescent group enough? Okay, we're really talking about morality, but are we doing something else? And what about POXA Act, which is complicating the issues? Okay, so all this, I think we can sort it out in this big forum. Next slide, please. Dr. Preet. Who are the panelists for this particular unwed mother? Dr. Preet and Ranjana.
Dr. Preet Agrawal and Dr. Ranjana Jha, any one of you can take this question.
Yeah.
Yes, ma'am. Can you hear me, ma'am?
Yes.
Yeah, nowadays we get lot of adolescents girls who are sexually getting active and they are not able to do. So we have to start from them from the beginning in the school. There are a lot of school programs there where we teach them about the sexuality and the other things, the chances of getting STIs and other things. So we have to start teaching them as soon as they get their menarche from school. We should not think that they are small girls. Don't worry, let them come to college, they will know that. So the POSCO Act is the prevention. the prevention of the prevention of the adolescents, the sexual act is there, which has come, it has started in 2012, and which has come in a long way, where the child has to be told that not only the sexual act is a problem, if anybody is behaving bad with you or is showing any things with you, anything behaving, any abnormal behavior also, you can always tell. And parents should be very, very open with the child. They should tell them that, look, that sexual health is not only to be hidden and not to be behind the things. They should be very clear enough and educate them about the do's and don'ts and what happens. Yes, there will be a lot of hormonal changes at that time, but the child has to be informed that this is quite natural and physiological, and how to tackle it and how to get over it is very, very important. So we have to start them at appropriate age and tell them about the sexual education and the medical barriers, and provide them contraceptions if they're really knowing about things, and they have to know about the implementation and monitor program for information and the service provision. So we have to make them a full range of methods available, and though they may not be very open with the parents, there are other people, the medical practitioners, the health workers, anybody can go and tell them about the different methods, especially the barrier methods, which is important. And they also have lot of if they get pregnant and or if they miss the periods or something, they have lot of psychosocial impacts are there, and to deal with it. So we have to educate them in a very good way. And suppose she comes unwed and she is got pregnant, yes, we have to offer them medical abortion and to offer, counsel them regarding the safe section contraception, and suggest contraception or any other methods if they're really socially active.
Next slide, Chitrakala. Next slide, Chitrakala. Next slide. Next slide. Yeah, this last scenario for the day, and Dr. Leena can take it up. I think all of us can offer. This is the age when they do not know what to do when they come with the unplanned pregnancy, unexpected pregnancy.
Okay. This case is going to Dr. P. Vasantamani ma'am. She is Mrs. Kavita Raju, 42 years, para 2 living 2, and she is not sterilized. Last child was 14 years back. She is apprehensive about delayed period. So whether
Indra Palo can join her.
Yeah, anyone can take these questions. Whether this contraception is required at the age of 40, where some other gynecological problem is also associated. So what is your take, ma'am?
Next slide, please.
Yes, ma'am. Definitely contraception is needed at the age of 40. But we think of other complications. We have to rule out which category they are belonging to. Whether there is a relative contraindication, there is an absolute contraindications for hormonal contraceptives. Whether they are interested in doing permanent method of sterilization, or they know the fertility period, whether they can go for abstinence and use the barrier contraceptive methods like condoms, male condoms, female condoms, because they are maybe not practicing regular sex. So they have a once in a while, so they can use the barrier contraceptive methods if they are fully aware of the things. But there is failure rate. But we have to know the real conditions, because at 40, they can have a satisfying sex if they fully use barrier contraceptives, or if they have a relative contraindication and absolute contraindication.
Next slide.
They can have an intrauterine contraceptive devices also. So copper IUCDs or levonorgestrel IUCDs. If they have any other medical problems like adenomyosis, any AUBs or interval bleeding, spotting, all these things. So they can have a levonorgestrel IUCD, which will take care of the other complications also.
Yeah. Madam, I think we have to take the history,
and
because
we have to counsel them. So whether they want a future fertility, whether they want a future children, and whether they have a need a reliable birth control, or they want to manage other symptoms. So we can have a permanent methods or abstinence, or if they have a fertility awareness, they can use barrier contraceptions. Even related
30 to
contraindications,
40.
no contraindication, they can use implants and liver nodules, IUCDs also.
But most of
So
the time, what
injectables
we
also
offer is
suitable.
sterilization. If they do not want future children in the future, the most common thing which we tell is once you have missed period and you are scared that it could be pregnancy and you have ruled a pregnancy, that's a nice time to counsel her for a permanent sterilization if she's not very keen on having one more baby. Okay, so that solves all the problem because this irregular cycle is going to be an issue beyond 40 years till she attains menopause, and the question of having got an unplanned pregnancy, embarrassing one at this age is also should be taken into consideration. So most of the time, what we offer once she misses periods and it turns out to be a non-pregnant delayed cycles, we offer them sterilization if they are willing to. Otherwise, best thing would be to put a copper 380A. Copper 380A will last for another 10 years, and by the time she'll approach menopause, and you can take it out.
Yes, that's the best.
Madam, if the best thing.
Any step like adenomyosis, menorrhagia, we can opt for liver nodules.
LNG in this matter,
We have to examine her and whether she is having any medical comorbidities also. So that we have to see. Then only we can advise.
And IUCD, for the sake of this, when you put in this people, they say you can give an extended time. That is, instead of removing her 5 years, you can give them for 7 years, and the current recommendations up to 9 years also.
Yes.
So we can keep it almost like a copper 380A, copper 380A, and be done with it.
For another 10 years.
Continue
Yes,
to
10 years.
menopause.
Yeah, she will because it's
No more embarrassment
between 40 and 50. The delayed cycle is a big headache for them. You know, like at 45, the girl should have just fixed up a marriage for a daughter, and she has missed periods. It's put a lot of embarrassing situations to the mother, and we can understand the situation. So they readily agree for whatever you say. By the time you put an LNG-IUS, it's under, let her complete the family function of wedding, whatever it is, come back and get a sterilization done. That's what I tell them. Okay, so if that is what the next.
If patient is fit for OC pills and she has premenopausal or perimenopausal symptoms, then we can also prescribe her low dose OC pills also.
Yes, madam.
Yes.
Even Femostone. Madam, Femostone has got very good role in menopausal transition. Femostone has got very good role. We are giving a Femostone molecule to these women when they are approaching with.
And at the age of 40, majority of the patient has either scanty menses or heavy menses. So this will also reduce by OC pills also.
Yeah.
So
Madam,
individualize
also
the
we have
case.
to
Yes.
counsel the partner, male
Yes.
partner. We have to ask them to undergo sterilization. Vasectomy is such a simple procedure.
I think as the age of 40 sterilization, we do not prescribe any patient to sterilization at the age of 40.
But woman has to suffer throughout her reproductive age.
And when the man has not agreed the whole life to get vasectomy, he will never agree after 40.
Yes, yes.
I always tell the patients, I'll put your picture in the.
Embarrassment is for both only.
Agree for vasectomy.
A late childbirth, it's an embarrassment for both, and responsibility for both the couples, isn't it? Not only to the female.
We have to popularize vasectomy because it is so simple method, but no one is ready. Percentage of vasectomy is
even their wives say, मेरा husband को छोड़ दीजिए, वो नहीं कराएगा. He will not get vasectomy done.
लेकिन बहुत कुछ चाहती है तो husband ready भी नहीं होता. वो नहीं ready.
No, I have seen wives don't allow their husband that they should go for surgery.
वो भी है वैसा दोनों है.
It's all a myth, ma'am.
Vasectomy is so easy. It must be popularized. It's very easy. Previous 3 cesarean को फिर से ट्यूब लाइगेशन करना, पेट खोलना फिर से, लेकिन vasectomy they do not do.
Yes. Slide, please. So we will ask our expert to conclude the session. Dr. Indra, is she available? Otherwise, I can ask each of the panelists, wonderful panelists we had, and we'll ask each of the panelists from Dr. Alka, 1 point. What you would take a message quickly.
I think she is not there.
Yeah, okay. It should start from the time she's
Individualized
planning for a
patient.
pregnancy.
I think we should start with pre-pregnancy counseling,
Yes,
and then the early, the younger age group, we have to concentrate more, give them more information about conception and contraception, and the methods to protect themselves. So the sex education at school level is very, very important.
Very, very important. Yes.
Important. And then, of course, finally, I would still stick on with Madam, as she said, we have to popularize vasectomy, particularly no scalpel vasectomy.
Yes.
Dr. Ranjana, one point.
Proper counseling, as Madam said, proper counseling is very, very important.
What a method you are prescribing counseling.
Either normal delivery or cesarean. I call the patient after 1.5 months, and proper counseling for the contraception I do after 1.5 months of delivery.
Kavita?
Yes, madam. Just proper counseling is very important, and we have to tell them that we are largest populous country in the world. So we have to control the population. We have to plan the family, because I say Earth has this one, and we are growing like this. So everyone has to take care of the mother Earth. Otherwise, our children will be deprived of even air or water or everything. So that we have to counsel even in school children, school going children. And then whenever any woman or any couple comes to us, we have to counsel them that even their mothers, mother-in-laws, and everyone, they have to. In our part, many women just beta, and they are going to plan more and more children. This should not happen.
On emergency contraception, as 1 point on emergency contraception.
For me?
Yeah.
Dr. Preet.
Ma'am, emergency contraception should be told very nicely to the, especially the living relationship that has come in a very big way. So we have to inform them that yes, USP regime is a very good regime, but don't use it many times. You can start OC pills instead. Okay, so that is very, very, we get a lot of patients who come in, live in relationship, casual check has become like the go of the world.
Dr. Basnamani on unmet what take-home point you want to give to the society?
Yeah, because we have to counsel the younger girls regarding this premarital sex, and especially we should give an awareness over the availability of contraceptive pills, emergency contraception, and safe methods of using condom and other things.
Condoms, yes.
If any unwed people becomes missed periods means, we have to take the call immediately, should rule out the pregnancy, or if there is a pregnancy positive, we have to give them an abortion services, and further we have to counsel them whether they are a regular practice of sex or once in a while. Either this pregnancy happened by slippage of condom and other things, and detailed history. Then if she's not in a living relationship and other thing, we can counsel her and have a safe sex. But if she's in a living relationship, we should give them a contraception which will take care of the frequent coitus, like combined oral contraceptive pills, or as Madam previously said, regular practice means we can give IUCDs also.
And before we close the session, can Dr. Alka and Dr. Akila put their video so that we can take a nice concluding photo shoot? Dr. Akila and Dr. Alka.
Nice to see you, Indira Appa.
Dr. Akila, photo video please. Dr. Alka. Akila photo. And I conclude this session with a big thanks to Jayarani Madam, who trusted in me to deliver this panel discussion in a short notice of 2.5 days. I had to modify whatever I had to suit the pan-India population. And thanks to Jayarani Madam for trusting in me. And thank you, ma'am.
Thank you for the opportunity.
For a wonderful platform, and for also for chipping in when my web went out suddenly. My connection was unstable for some time.
Bharti Madam, namaskar.
Thank you so much.
Good evening.
Preeti,
very happy to see you after a long time.
Thank
you, madam. I was trying to connect, but don't make the connection so complicated. So I asked Indira, you give me the speaker link. She sent, then I connected 2 to 3 times in between. So very nice discussion. We all are happy. Gain much of knowledge. Is this the last session of your webinar today?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you for joining us.
I have
Thank
joined
you for joining
in between. So now only I am showing in video.
All the
So I love
best
to
for
see my
everyone
student.
who is contesting. All the best.
know,
for everyone.
A big
how
round of
Preeti
applause
has
for the
been-
panelists and the moderators. It was wonderful.
Yeah.
Thank you, madam.
Wonderful.
Very
Best of
special
luck to Jairani ma'am and
special
Suman
thanks to
Kinna.
Dana madam,
Thank you very
who has
much,
taken
madam.
up within 2 days, and she made this panel a real marvelous.
Yeah,
knowledge
marvelous.
panel.
Yeah.
Thank you, Dana madam, for this fabulous, amazing, awesome way you make everything very perfect, and everybody had the very best. You've taken out the best from everyone, and it was a real good knowledge sharing. Thank you so much.
Before concluding, may I say something about this contraception, another aspect of this contraception? All of us discussed about the oral contraceptive, hormonal contraceptive, but regarding the Centcomman, which is available in the government hospital, is Chaya and Saheli. This is a wonderful molecule without any, it is not a non-hormonal, whether you find any contradiction for the, you are not prescribing non-hormonal contraceptive. And anyone who is above 40 years,
Poverty-induced heavy menstrual bleeding. This is the best solution.
this is the best contraceptive in a woman who are above 40, and this should come it is very cheap and it's affordable. And
Is it available outside or only government setup?
No, only it's available in the
in
hospital.
outside also Saheli. Marketed as Saheli.
That will be costlier, I think.
This should everyone should know
It's
about this.
available outside
Be
also.
confident. The doctors must
Yeah.
be confident to
Yeah,
prescribe,
we advise women
and
they
should
take
the
from the
government also
outside
should
clinics.
promote it. That
I
that
am
is best
prescribing
contraceptive
breast
for
tenderness also.
breast and so
That
many
we are
women now
giving.
are coming with the mastalgia.
Vista
Yes,
we are
I
giving.
am
A
prescribing
woman who is
Vista.
complaining
Vista is
heavy
the market.
menstrual bleeding over the age 40 years, need a contraception, heavy menstrual bleeding. That is the best option you can prescribe for a. It is very cheap and it is affordable and is very good, convenient also. That government
But the contraception
also.
efficacy is
We
not
can
that
give
much.
in lactating
And the
women also.
contraceptive
In
efficacy is
mastalgia,
best.
excellent result.
Excellent contraceptive effect. So
Yes.
many people are discussing regarding the hormonal contraceptive, but this is the one where is diabetes is there, hypertension is there. You are not able to prescribe for a long time hormonal contraceptive. The people and the doctors should come up with this molecule and should in a better way so that we can have a good choice. So this will control her high estrogen level and mastalgia also. This will look after her heavy menstrual bleeding also. And we also should promote non-hormonal contraceptive because we know there are so many limitations.
We are promoting Saheli
Yes,
in our
I am
participant.
also.
Saheli.
So
Saheli
if
comes in our
any contraceptive, we are having any
I-
contraceptive discussion. This should also be a part of this discussion and part of where you should.
Sure, madam.
Yes.
My next set of
One-
slides will
one more
have
thing.
one session
Madam,
on
one more
Saheli.
thing I want to add up with the emergency contraception about the levonorgestrel, which is actually, that is the drug that is given available in the government setup. No, that is not available in the private
Yes,
because
ma'am.
that is a eye pill, which is very importantly that is
It is
available.
available in
It's
Only
available
government,
outside
with the
also.
corporations, it is available. It is
We
not
are
available
telling
in
them
the private or in the private institution. That's a very good emergency contraception, and we have made request to the
It's
government.
available
to make it
outside
available.
also. Levonorgestrel is
It's
available, ma'am.
in
Yeah, available.
urban
Yes,
primary
we are
health centers are
prescribing.
having this emergency contraception, ma'am, in Chennai Corporation.
Yeah, that is one thing that we should get. It's a very effective emergency contraception. It can be given with
Nowadays,
very
nowadays,
high safety.
most of the literate women come with taking IPL. कि madam हम IPL
Yes,
खा लिए
yes,
विराट
yes.
को हुआ था, so
That's
अब क्या होगा? So most of the literate women come with IPL.
Because other pills have within 72 hours, but Ulipristal can be taken
Up to 5 days.
Yes, that
Very
is the
nice
best
cost
part
for
of
you,
it.
madam.
Even copper
1,800
IUD.
rupees for
Copper IUD also can be given up to 5 days. हाँ.
copper
Yes,
IUD
yes.
is the best.
Thank you, madam. Thank you so much for this
Thank you, madam.
vibrant and very
And
voracious
all the best to
contraceptive, which is the
Suman madam
real
and Jairani
important
Kamraj
one.
madam.
Thank you, Jairani.
Jairani madam.
Thank you.
All the programs.
All the best.
A formal,
Thank you,
a formal,
Jairani
and
madam.
give-
Thank
give-
you.
I want to give a formal thanks to
means
one and
again-
all. I have a very special thanks to our chief guest, Dr. P.C. Mahapatra sir, who has been there to bless us, and as chief guest, and the guest of honors, Rajesh sir and Alka madam, for their wonderful presence to bless our webinar, which is a real amazing success we had. And a very special thanks to Dr. Arun Kumar Singh, Madam Kalyani Singh, and Saswita Smith. Madam Kalyani madam, I think I'm sorry for not with the proper introduction. We sorry because we couldn't get the proper CV. We couldn't introduce you. So good. So thank you so much for being with us.
Madam CV was there.
Yeah. Yes, there was a little confusion in that. And there was a little connection also was a problem. And the very special thanks to the chairpersons, Dr. Sujita Kumari, Shri Priya Jaiswal, and Vinita Madam for being with us. And I owe my best thanks to the speakers, Meena Saman for her very good talk on the bone health of the women, and Deepa for her very wonderful, elaborate content on the midlife crisis. Wow, a very voracious one you have made, and the very dynamic, vibrant of all the events, that is our contraceptive panel. Thank you, Preeti. Thank you, Kavita Madam. Thank you, Ranjana Jha Madam. Dr. Vasnamani Madam, Dr. Lumi Madam, Chitra Madam, and all the Ranjana Jha Madam, Alka Nadar, that Preeti Agarwal, everybody who has joined with a short notice to make this as a very grand success. And thank you, special thing to Akila for making everything in a proper way. And very special thanks to the platform given by Shield and Sahitya and Chitrakala for being with us all through the Sunday evening. In midst of your Sunday evening, you are being with us, which is a very important way to share the knowledge and dissipate the knowledge. Thank you so much. Thank you one and all. We look forward and kindly support Suman Sinha Madam and myself and Kavita Madam for all our election support.
Thank you.
We look forward
Thank
to
you,
work
Jayarani
together.
Madam.
We will
You
look
told
forward to work
in the
together
syllabus.
and
Yeah.
make our knowledge share.
Thank you.
Thank you so